morning, everyone. My name is Premila Nair, and I will be your host for this event. I'm excited to welcome you to the launch of our masterclass series entitled Forward Malaysia Charting New Paths to the Next Normal, proudly presented to you by Newcastle University Medicine Malaysia in collaboration with the Malaysian Advanced Acute Internal Medicine and Ultrasound Society, supported by the Ministry of Health. I do hope you are as excited as us to listen to our esteemed speakers and panelists who will be imparting their insights on the current COVID-19 crisis and what the future holds for us. Without further delay, it gives me great pleasure to introduce the CEO and Provost of Newcastle University Medicine Malaysia, Professor Chris Baldwin, to give the opening speech. Professor Baldwin, please.
Thank you, Pramila. Tuanku, Datuk, professors, doctors, colleagues, and all of the medical students and fresh medical graduates that are here today. Saya mengucapkan selamat pagi. It is my very great pleasure to welcome you all to today's event, Forward Malaysia, Charting New Paths to the Next Normal. This event is hosted by Newcastle University Medicine Malaysia in conjunction with the Malaysian Ministry of Health and the Malaysian Advanced Acute Internal Medicine and Ultrasound Society. I would firstly like to welcome all of our speakers and contributors today. Tan Sri Dato Seri Dr. Noor Hisham Abdullah, our own Director General of Health here in Malaysia. Duli Yang Taramat Mulia Tuanku Saeed Faizuddin Putra Ibni Tuanku Saeed Sirajuddin Jamalulal, the Raja Muda of Perlis. Datuk Dr. Noel Thomas Ross, National Head of Acute Medicine. Datuk Seri Dr. Paras Doshi, Consultant Physician of Acute Medicine and President of the Malaysian Advanced Acute Internal Medicine and Ultrasound Society. Dr. Lechman Ramnathan, National Head of Medical Services. Dato Dr. Mahiran Binti Mustafa, National Head of Infectious Diseases. And Dato Dr. Suresh Kumar Chidambaran, Head of the Medical Department at Sungai Buloh Hospital and Consultant Physician of Infectious Disease. I would also like to thank Khairi Jamaluddin, Minister of Science, Technology and Innovation, who was originally scheduled to attend today, but unfortunately has had to pull out to attend to another important appointment this morning. We at NewMed are very proud and honoured to be hosting this free event today, which is primarily aimed at informing medical students, fresh medical graduates and junior doctors across Malaysia about how Malaysia as a nation has successfully managed to deal with one of the greatest medical emergencies of our time, and also to discuss advances in acute internal medicine. I think that you will all agree that with such an eminent panel of speakers that we can look forward to an exciting, stimulating and highly informative series of presentations and discussions this morning. And I'm really looking forward to watching them all. From my personal point of view as an immunologist, we can see that infectious diseases are still a great threat to both individuals and society as a whole, as quite obviously now evidenced by the current pandemic. But COVID-19 is not the only infectious disease that we have to consider as we go forward. We have the constant threat of other emerging pandemic viruses escaping into the global population. There is a well-recognized worldwide problem with the development of antibiotic resistance in bacteria, and there are ongoing battles against such infectious diseases as tuberculosis, HIV, dengue, malaria, Ebola, and Zika, amongst many others. Thus, I can see that as we go forward, that both the clinicians and bioscientists amongst you all will have to face the challenge of infectious disease for many years to come. Although we may see the light at the end of some tunnels with the successful development and deployment of a number of the new vaccine technologies used against COVID-19, and these may be translated to prevent or treat other infections in the future. Can I just remind you here that after our morning sessions, we will be hosting a number of further meetings in the afternoon discussing training pathways for junior doctors. And can I ask you to please refer to your emails for the links to these sessions. Finally, today's event is the launch of a series of free online webinars that NewMed will host with the MOH and MAAIMUSS, amongst others, over the coming year. These events will bring together experts from the Ministry of Health, academia and industry to discuss the healthcare challenges and their potential solutions that we will face, both here in Malaysia and globally as we go forward. And we look forward to seeing you at these events in the future. Thank you, and I wish you all a very successful day.
Thank you very much, Professor Baldwin. I hope you're all excited to hear from our keynote speaker, Tan Sri Dr. Noor Hisham bin Abdullah. It is really unfortunate that Tan Sri could not do a live session due to his extremely busy schedule, but he has so very graciously agreed to deliver a pre-recorded speech on a very widely discussed topic, COVID-19 in 1 year, what we know and where do we go from here. It now gives me great pleasure to introduce our keynote speaker, Tan Sri Dr. Noor Hisham bin Abdullah, Director General of Health, who is no stranger to us. Good morning, Tan Sri, and a very warm welcome from Newcastle University Medicine Malaysia. Tan Sri Dr. Noor Hisham bin Abdullah has been at the forefront of healthcare in the country and has been a recipient of many accolades. One that I would like to especially mention here is Tan Sri being awarded the Newcastle University honorary degree of Doctor of Medicine in 2014 in recognition for his outstanding contribution to surgical practice, in particular to the development of endocrine surgery and clinical education in Malaysia. Tan Sri has always emphasized the importance of learning as a lifelong process, which is why it is only fitting that we have him here with us to share the learnings from COVID-19 in 1 year, what we know and where do we go from here. At this juncture, I would like to welcome Dato Sri Dr. Paras Doshi, an acute medicine physician who's based in the almost evergreen state of Perlis, to join us. Dato Sri?
Thank you, Premila and UMed for having put this fantastic webinar together today. A very good morning to all attending our webinar. It gives me great honor to introduce our keynote speaker, someone who actually needs no introduction. This is a figure who is Malaysia's answer to Tony Fauci. The obvious difference, of course, being the age and the hair color. Tan Sri is someone who has almost single-handedly saved Malaysia from the brink of capitulation to the worst viral pandemic of our lifetime thus far. Tan Sri Dato Sri Dr. Noor Hisham Abdullah. As Director General of our Ministry of Health, he has successfully steered the country over the course of multiple pandemics in the past decade, including SARS, MERS-CoV, and of course now COVID. In addition to this, Tan Sri also plays an active role in multiple capacities in the World Health Organization. Tan Sri has been an ever-present constant, tirelessly toiling, preparing, mobilizing centers and personnel, equipment and garb, always motivating all the frontliners. Managing all this in addition to keeping the healthcare services running along is truly no small feat. Tan Sri has successfully led us through 2 waves of this pandemic. And now, as the third wave slows down slightly, and with vaccines on the horizon, it is only appropriate that we learn from Tan Sri as to what he has envisioned for Malaysia moving forward. Tan Sri, Dato Sri, Dr. Noor Hisham Abdullah.
Thank you very much, Dr. Sri Paras, for the kind introduction. And I was given this topic, Forward Malaysia, charting a new path for the next norm. We are living in a very challenging and difficult times. If you go back to where we started, I think in last year, we prepared our first case documented on the 25th of January 2020. However, we started preparation for the COVID-19 since December 2019. So to date, we look into the census. Globally, more than 110 million people has been infected, and in Malaysia, about 283,000 has been infected, and the total global fatality is about 2.45 million. In our country, it's about 1,056 cases been documented. So the first case in Wuhan occurred in 2019 and spread to the rest of the world. And we share almost about 80% similarity with SARS-CoV-1. This SARS-CoV-2 is a bit unique in that sense. And globally, availability of safe and effective vaccine and continue to practice public health measures are the two most important armamentarium that we have to combat this pandemic. So we hope that we are in the beginning of the end with the vaccine, and hopefully end of this year or even early next year that we can uh, end this pandemic. So in our journey from 2019, where we started preparation of our IMR lab in terms of the testing, and we look into the genomic sequence of the virus being released on the 3rd of January 2020, we started to prime our lab and started training our public and our private labs to be ready to, to able to detect the virus. So our first patient was documented on the 25th of January, when 3 cases were reported, from Wuhan. And since then, we have 3 outbreaks. The first wave started on the 25th of January until 16th of February. We have 22 patients, no fatality then. Most of the cases were related to tourists from Wuhan, directly or indirectly. Then for 11 days, we have no cases. Then on the 27th of February 2020, we started to experience our second wave, contributed by 3 main clusters, the UDA cluster, the Sri Petaling clusters, and immigration, and from those detained in the immigration center. So that was the challenge, and we were also anticipating Malaysian returnees from abroad, from 5 countries then, that is from China, Japan, Korea, Italy, as well as Iran. And during the school holidays, many Malaysians already have booked the tickets to visit or tour these 5 countries. So our concern was that when they return, they will bring the infection to our country. And we started also being challenged by the cluster from Sri Petaling. We were informed on the 9th of March that one of the participants from Brunei who attended a meeting in Kuala Lumpur was infected, was infected, and we were informed by our colleague from Brunei, and straight away we went to this mosque in the Sri Petaling, but unfortunately by then it was too late. There was a gathering of 15,000 people in that mosque from 27 February to 1st of March, and of which 1,500 from abroad and the rest from local. So they have returned back to their own state as well as country. So that was a big challenge because certainly there was an infection going on. We were also informed that 695 of the participants were from Indonesia. So, and most likely at the point of time, the virus could have been brought over from Indonesia. That was what we anticipated, but now we have evidence to show it is from Indonesia. Then we started on the 18th. We managed to convince the Prime Minister to start the lockdown, and we managed to contain the infection within a period of 4 to 6 weeks to use our public health strategy and complemented by the total lockdown on the 18th of March. And certainly within 4 weeks of total lockdown, we see we managed to flatten the curve, and this is a good sign. And but having said that, during that period of time, it was Ramadan and before the Eid celebration. So we continued the lockdown until the celebration, and we managed to bring down the cases if you look into cases to do lower 2-digit or even single digit. So our baseline before the first wave was 0 cases, and our baseline after the lockdown was about 25 cases, about 2-digit. On the 16th of March, 16th of July, we managed to bring the figures down to 0 cases for 3 days. So we were doing very well, and we live up all the lockdown. But more importantly, we complied to the SOP. However, the 3rd wave started on the 20th of September following the election in Sabah. And that's where we can see that the third wave is more challenging than the first and second wave. However, we are more prepared at the point of time in terms of our health facilities and etc. So if we were to look in details about the three waves I mentioned, the first wave mainly involved the imported cases from Wuhan. Second wave, you can see the red columns from imported cases or Malaysian returnees from overseas, and the green is local cases, and the yellow is local but non-citizen. So over the period of time, you can see that our local community infection is increasing among the locals. Although it started towards the end of the second wave, you can see the non-citizen, mainly the documented foreign migrant and undocumented cases. So the evolution of the SARS-CoV, we have learned a lot from the start until today. And in the beginning, the early outbreak mainly are related to tourists from Wuhan, and the virus is also from Wuhan, a B Wuhan ancestral. And during the street tiling gathering, the street tiling cluster and the detention center, we realized we did a study and shows that it is from a C derived, mainly as what we anticipated earlier with the strain coming from Indonesia. And lately, I think we are seeing a B derived with multiple spike protein mutation clusters from Kedah, Johor, and Sabah. So we can see the virus is mutating, and the strain is different from one region to another. And this is where I think the genomic sequencing certainly helped us in the surveillance. So the transition of the spike gene protein mutation, no persistent spike mutation were noted earlier during the first wave. But subsequently, we have seen the mutation, spike protein mutation of D614 from returnees from Sivaganga, India, as well as from cluster Tampoi from Manila, and a few more clusters from Ops Benteng or in Sabah. So, and we have seen this D614 is spread very fast in Kedah and involving a few clusters, Tawa, Sungai cluster, Tembok, and etc. So I think what we have concluded at that point of time last year was that D614 have a higher infectivity, but in terms of the fatalities, still remain the same. Then lately, from the Ops Benteng during the third wave, so we have sampled more than 32 random sampling of the specimens, and we realized that there was actually an increase of D614G, about 100% of the sampling, and A701 virus, A701V virus mutation, and this is again about 70%. So the virus keep on mutating, and we heard that from other countries as well, in UK, mutation of B117 in South Africa, in Brazil, and in other countries as well. So our concern at that point of time is that you look into our strategy during the second wave is to strengthen and our borders, make sure that we can control the incoming Malaysian returnees or even tourists coming to our country. Border control is very important. Second, we are looking into the strategy of preparing our health system to accommodate patients in time to come. And third, from our experience, the public health measures works well. Initially, there were two schools of thought. One is the public health measures, prevention and control, and the other is the herd immunity approach. So we do not know at which point, at that point in the time, which approach will be better, or even there was actually a two school. But having said that, after 10 months, we see that those who have adopted the herd immunity approach, their fertility rates increases more than those who have adopted public health and control measures. So I think now many countries are using the public health and control measures. So our approach to this pandemic COVID-19, so we look into the whole strategy, a whole government and whole society approach. And most important is the public health measures, surveillance and public health intervention. So once we detect a case, active case detection, contact tracing, community and entry point screening, mandatory quarantine for those and home surveillance order being given for those have been exposed to a positive patient or suspected. So we continue to enhance our SARI, our ILI screening and surveillance. And also we have stepped up the pre-operative surveillance in our hospitals. And more importantly is that we are adopting a targeted mass approach testing. So targeted testing, but it's in large volumes of patients rather than to test everyone. So then we have a better outcomes in terms of the detection, mainly in the high risk and vulnerable population. So mass screening, we adopted the mass screening strategy mainly for the foreign workers. That's our focus group, but more targeted in our approach. Then protect the healthcare workers and safety. This is very important. So we continue to make sure that we have enough PPE and protection and etc. And healthcare deployment. This is another things that how we approach our problems when, for example, in PRN Sabah. So there's a spike of cases in Sabah. So we are able to mobilize our staff from other states to deploy them to Sabah. So that is somehow we try to optimize our resources. And mental health and psychosocial support for our staff and our patients, and community empowerment. This is also very important. So we adopted the 6 strategies, as I mentioned earlier. 1 is the border control. 2, health facilities enhancement. 3, continue to embrace public health measures. 4, protection of the vulnerable population. 5 is strategic communication with the public and our patients. And the most important is the community empowerment, the 6. So we have started the diagnostic and detecting testing much earlier before the pandemic. So the preparation is, if you look back, I think the most important is our preparation in terms of to handle this pandemic. And movement control order, that is actually a tall order coming from the government of the day. It's a big decision by the government, and we had a whole government and whole society approach led by the National Security Council, and so we are working closely with other agencies in not only from Ministry of Health but other agencies with immigration, police, armed forces, and etc. So that movement control order does help us in terms of to employ our public health measures. And whatever we do, most important, it must be evidence-based. So we do have national guidelines on the COVID-19 management, infection and prevention control protocols and training. When we look into our preparation and response, I think we had the experience in the past handling multiple outbreaks before, like SARS, MERS-CoV, H1N1, and etc. So our preparation from that experience that we had, it gives us the basic preparation and the fundamentals in terms of what we should do and what we should not. However, when we do recognize that in terms of digital health and technology, we are a bit lagging behind, and perhaps because this is still evolving, and we are more reactive rather than proactive. Other measures are more proactive in that sense. And strategic communication, again, this is ongoing, how we engage with the public, we calm the public, what, the do's and don't, remind them what not to do, how to protect themselves, community engagement, and most important in current situation is that we are not only handling the virus, but also the viral or the fake news. And this is, damaging because it can create confusion in the public as well as public disorder. And our strategies in terms of when we diagnose the patient initially was to isolate them and to manage them in our quarantine center or even hospital. But as the cases continue to soar, and we have to actually manage them and make sure that we can isolate them from the community. So we are not able to cope in our quarantine center as well as in the hospital. But we started, employing the COVID assessment center and unified command center for us to manage those patients so that they can be isolated at home. I think we have started this recently because when we have volume of patients, this is the best way, probably for those who have low risk as well as have a proper accommodation at home, so we can maximize the resources at home rather than in our PKRC, which is still ongoing, but we place those who are high risk and category 1 and 2 in our PKRC. And most importantly is the preparation, looking into our manpower, looking into our equipments and etc. So I think we are looking a more diverse approach and how to maximize the limited resources that we have and optimize it from time to time. So our Malaysian preparedness and planning began since December 2019. So we do have our CPRC in place and come up with a health ministry guidelines on management from time to time. So we had our first guideline on the 17th of January 2020, and we continue to learn about this virus. For example, initially before we discharge our patient at the early phase of the pandemic in 2020, we need to have negative results before we discharge them. 2 negative results from 72 hours apart. If they are negative, then only we allow them to be discharged. But later we realized that some of the patients have to be quarantined more than 2 weeks. I mean, some 30 days and etc. So then when we have evidence to show that it's not necessary to quarantine them for such a long period of time, although the RT-PCR result is still positive, then I think this is where then we started to cut down the 2 tests to 1 test before discharge, and our quarantine was 14 days. And then we realized that from the evidence studies from Canada to show that the infectivity rate, infectivity is mainly for 7 days, and on the day 10, a very low infectivity rate, but it's still positive. The test was still positive. So which means we have cut down in terms of the test, and we also are able to cut down the incubation, the 14 days to 10 days, and we discharge our patient on the 10th day. They may still be positive, but they are not infective. So Ministry of Health Crisis Preparedness and Response Team, we have the National CPRC, and we started functioning on the 23rd of January, and this is where we coordinate and collate our activities and getting the data from all the states. We also have a Hospital Services CPRC to manage our health facilities, and we have the State CPRC and Hospital Operation Room, giving us the information from each respective state to the central CPRC, and we coordinate information. Every day at noon, we'll get all the information and we analyze the information and release for the day. So the Ministry of Health Hospital Preparedness and COVID-19, so we have initially was our alert phase in terms of screening hospital, treating hospital. We identified our hospitals and how best we can optimize the resources in our hospital. And we identify our hospital beds, ICU requirement, and also the lab. We started with 23 labs, and now we have already increased to 68. Our capacity from 100 tests a day to about 76,000 tests a day. So we are trying our best now to increase the testing to about 100,000 a day. And we are also in the process of upgrading and install new labs in our district hospital. So then we move on to the early containment. So this is our activities that have been done. The low risk treating and quarantine center. It is important to uh, uh, help us to reduce the patient load in our hospital. So this is mainly for category 1 and 2, and continue to increase our lab capacity from 25th of January to until 15th of March. Then the late containment phase came in from 16th of March to December 2020. And this is where you can see we have stepped up our laboratories capacity, our low risk treating and quarantine center from 924 beds to 16,260 beds, and the ventilators from 50 ventilators to 1,581 ICU beds. Even hospital beds has increased, and the hospital, treating hospital and screening hospital also have increased. So currently we have more than 120 screening hospital and 69 treating hospital. And hospital beds total about 8,368, ICU beds of 604. We do have 2,009 ventilators in place, and we have 23,206 beds in our quarantine center. And our laboratories capacities are 76,805 with RT-PCR. So we are enhancing our testing with the RTK antigen as well. And apart from the low risk treating and quarantine center, we are now also using the home isolation or home quarantine for category 1 and 2 but low risk patient. So the targeted approach of mass testing, screening and surveillance have been performed. So surveillance activities will continue. If you look into our monitoring of the current situation, we depend on the 6 indicators. The first is obviously the daily cases and new cases and discharge. Second is looking into the fertility rate. Third, also we monitor using the R0 or RT, the reproductive number, and to see the trend. Most important is the trending. And fourth is that we look into our healthcare beds facilities being used for ICU as well as hospital wards. And fifth is looking into the numbers of the healthcare workers being infected or exposed to the positive patient, and they have to be quarantined. So our workforce will be weakened if the cases continue to rise. Last but not least is looking into the testing. The number of tests a day that we do using RT-PCR or RTK antigen, as well as surveillance screening, sentinel influenza like illness screening, severe acute respiratory infection screening, healthcare worker screening, and pre-operative screening. So it will give us, the whole radar of the cases in the community. And on top of that, person under investigation screening has been done, close contact, community screening, symptomatic screening, ward and hospital admission screening. So for hospitals in the red zone, so we do have the hospital admission screening as well. Pre-employment screening also has been done. Workplace screening, for example, now under our SOCSO, we do screening. We have done more for the foreign workers. We have done more than 412,000 cases, but the positive rate is about 1.8%. And the self-screening, those who wanted to be tested can come forward in the private lab and to do the screening. We also test and screen those brought in death to the into the hospital. And before we do any post-mortem, we will wait for the results. And arrival from high-risk area, so screening, for example, after the state election, those coming from Sabah, we'll screen them. So screening of targeted group, this is also we have done, and there's a cluster of street styling, so Tafi School, and etc. So when we identify certain targeted group, and we will continue to focus our screening and detection of the cases in the community. Total individuals tested as of 21st of February is 5.8 million population in Malaysia. The conceptual framework of public and private healthcare services integration for the management of COVID-19. So to optimize the resources, because you do know that in Malaysia we have a dichotomous healthcare system. So it's important for us not only to maximize our resources in the public sector, but also to integrate our public and the private sector. So we have worked together with the private hospitals as well as GPs, and then we form this COVID assessment center. Those who have diagnosed can actually step forward to this center, and risk assessment will be done, and we do the risk evaluation. If they are low risk and have a suitable home, they can be quarantined at home using MAAIMUSS home monitoring system. And for those category 3, 4, and 5, we have the unified command center looking into how we can and monitor the beds availability in the private hospital or certain hospital, or even the ICU beds. So we have brought in the private hospital, the Ministry of Health hospitals, the Unity and Armed Forces Hospital, and also the PKRC. So this is just like a very holistic approach, monitoring all those category 3 to 5, and we can allocate them accordingly to the respective hospital beds and the ICU. This is our COVID-19 assessment center, the flow chart. How do we assess them? And then if they are high risk, stage 4 and 5, immediately we admit them to the hospital. If they are stage 2, moderate, then probably we will admit them to the quarantine center and then observe them closely. But if they are stage 1 and mild stage 2, we will place them at home for monitoring using our MAAIMUSS. The attention now, perhaps, as I mentioned earlier, apart from the daily cases, new cases and discharge cases, we are looking into the R0 or RT. Initially, we started the second wave with R0 of 3.3, but we managed to bring down the reproductive number to 0.3. And at one point in time, we have 0 cases and very low cases during the second wave. But when we started the third wave, our R0 is about was 2.2, and then we implemented on the 14th of October the MCO, basically CMCO, and the CMCO we allowed the economic activities to function, but not the social, education, and sports activities. And we managed to bring down the R0 from 2.2 to 1.2. And since then, it was difficult for us to bring it down further. And on the 7th of December, because of our decision to allow interstate and inter-district travel, and because a virus is already in the community, and we hope that the public, it's onus on the public to comply with the SOP. But I mean, we can see that many of our public have flouted the SOP and continue to have this interstate travel, and the cases since then spiked during the Christmas and also New Year, and it has gone up to about 1.2, the R0. And on the 13th of January, we have decided to implement the MCO again for 4 weeks, and we have seen now the results of the MCO 4 weeks. The peak of cases been detected was on the 29th of January 2021, of which we have 5,700 cases, 5,725 cases then. And since then, now we are seeing a plateau and a decline of cases, and we hope that that will bring down the R0 from 1.2 to 0.8. So we are there, but we are not out of the woods yet. So we hope that now we'll follow the trajectory of 0.8. But our intention is to bring it down further, the R0 to 0.5, which means if we have 1,000 cases a day, then if it's 0.5, sustain 0.5 for next 2 weeks, we are able to halve the cases to 500, and eventually 250 and 125, and continue to flatten the curve. So that's our trajectory that we hope that by end of May 2021 that we will see 2 digits of our cases a day. So we continue to monitor our R naught or RT, you call it, and you can see the spike of cases was on the end of January, and then we continue to see a decline of cases now. Now is a little bit plateau on 0.9 and 0.8. We hope that the next couple of weeks it will comes down further. Now, the COVID-19 trend citizen versus non-citizen, initially, you look into the third wave, we see here is that initially it started among the foreign workers, whereby the non-citizens much higher, about 65%, and locals about 35. Then eventually, towards the end of February 2021, the citizens are more infected than the non-citizens, which means to say that the virus is already in the community. The outbreaks can be in a prison, can be in a certain communities, for example, like foreign workers, but you'll infect the locals in the community eventually. So, like in the prison, the same thing. Although in detention center and the prison, infection occur in the contained environment, but the workers, for example, and officers coming in and out may be infected, and when they return home, they infect the family. The wife goes to market, the wife infect the community, and the children, for example, go to school and they infect the schools. So this is where we need to contain the infection as soon as possible. If we can detect the positive cases, we need to step up our contact tracing and isolate the potential cases. And this is a sporadic cases also have increased since early 2021. Initially, our cases of cluster cases about more than 60% in second wave, but now you can see 70% of the cases are sporadic, and clusters about 25%. Now, the mortality rate, although the mortality rate has decreased, but the number has increased. So, and you look into our cumulative death from day one until now is 1,056 cases, of which 88% are mainly locals, and 35% comes from Sabah, 65% involving male, and 85% more than 50 years and above, and 88% had one or at least one comorbidity like diabetes or hypertension. 21% was died from before reaching the hospital, brought in death, and 88% of our cases presented as stage 4 and 5. So if you were to look into our total deaths in 2020 was 471, and today only 2 months we already have 585 cases. So total of 503 died in the hospital and 82 brought in death. So I think this is our concern. And now our 5 strategies that we are looking into 2021 is, number one, is that we continue to use public health measures to break the chain of the virus infection. Number 2 is that we need to bring down in terms of the morbidity and mortality associated with COVID-19. Number 3, I think is important for us to step up our testing capabilities. Now we are using RTK antigen as well as RT-PCR. So RT-PCR namely for diagnostic, RTK antigen for screening. And the 4th most important is looking into a glimmer of hope for all of us is the vaccination. So we will start our vaccination program on the 24th of February. Phase 1, Phase 2, Phase 3, and Phase 4. We hope that we will complete the vaccination program until first quarter next year. So that will certainly help us. But last but not least is that we need to embrace in terms of the new norm. Meaning, even though we are vaccinated, we still need to protect ourselves. Vaccination give us the internal protection, and public health measures give us the external protection. So we need to use both strategies to break the chain of infection and protect ourselves. So we hope that this will continue, and this is a new norm that we have to adapt. as whether we can continue to return back to our normal life before the pandemic. It is something that we hope we can, but until we have looked into the success of the vaccination program, whether it will give us an immunity passport, so it's left to be seen. So we need time for us to adapt to this new environment. So as we are living in certainly a very tough and challenging time. But more importantly is that for us to adapt to this new environment that we have. So until then, we cannot return back to our normal life. So this is certainly a very important balance between health and economy. So how to strike the right balance between health and economy? And this is certainly not easy for us to look into the two sectors. But the health involved not only the economy, but also social, politics, and etc. So life and livelihood, this is something that we have to make our decision based on these two important factors. In fact, you look into the definition of health, it is also looking into the well-being of the people. So well-being consists of economy, social, and etc. So the finding of optimum balance between health control and the economic livelihood. How can we strike a right balance? If we are very rigid in terms of our implementation of COVID-19 in terms of movement control order, then there will be also impact on economy and and politics. But we can contain the infection. So if we want to adopt this strategy, it must be a short-term pain and the long-term gain of the economy and the social and also the politics. On the other hand, it's not easy because every day to shut down the whole country, it will cost us about 2.4 billion ringgit a day. So that decision is not an easy decision to be made. But on the other hand, if the cases continue to rise and soon and we lose control, then the economy will go down as well because more people will be infected, more factories, more sectors will be closed because of the infection. And this is where it's not easy to strike the right balance. You do, you're damned. You don't do, you're damned. So this is something that is very tough going for the government to make the right decision because you have two schools of thoughts. But as a leader, as a government, we have to make a decision that benefit the country. So I think our role is to advise the government, the National Security Council, and we try to balance this in terms of life and livelihood. So the transformational effect of COVID-19 on medical education. So new emerging competencies needed in terms of how we do things differently. This is not the strongest and not the most intelligent people will survive. It is the one that adaptable to the environment and the changes. So we need to look into data technology in medical education. So that I think the technology is available but will not been utilized over the years. No reason for us to use it. But now we have all the reasons to use data and technology. For example, we are doing it now, video conferencing. Second is adapt to adopt e-learning and the simulation technology and use critical and innovative thinking in providing medical education and application of medical knowledge and participation of multidisciplinary organization. We do know from this experience, we cannot live, we cannot work in silo. We need to work with other parties. How can we come together and brainstorm, think out of the box to improve our healthcare in this country or the medical education, for example. The healthcare personnel, for example, needs to update the new and unknown about this virus. So we continue to learn. Each day brings new lesson for us. And once we know, then we can actually come up with the strategies to contain or even to eradicate the infection. And we need research work. Research work is a very important tool. Apart from services, research and training. And we need good leadership in terms of the top down and bottom up, and to see things beyond a new path. So, and provide us solutions rather than problems. And medical educators to avoid the three C's and practice three W. So this is something that the SOP has been put in place. Avoid a close conversation, confined space, and also crowded spaces, and practice hand washing, physical distancing, and wear a mask. So our strategies now, in terms of strategies for limited clinical teaching methods, we should evolve, looking into multiple approaches, how we can adapt to digital world, to use, to monitor, even to teach, and prioritizing the e-learning, for example, and maybe create a green bubble, so that we can have physical meeting, but in a green bubble. But most of the education can be done online and adapt to new technology as well. So the Ministry of Health housemanship intake and training during the pandemic. So, for example, new housemen given COVID-19 preparation lesson online before deployment to the hospital. And then the training guidelines can be introduced online. And, a lot of things can be done differently if we put our minds and heart and minds into the evolution of technology. So pandemic readiness as well, we need to look into the mental preparation. Most important, the question is, are we ready to adopt or change our mindset? The most difficult stumbling block is the mindset, and not able to change our mindset. So I think the students must come up with knowledge, in terms of adapting technology to come up with new ways, new means of education, and hopefully by doing so we can create a new norm for the future, moving towards the future in preparation for the next pandemic, perhaps. So our national COVID-19 immunization program mainly is a voluntary, it's not mandatory, for 18 years and above. Some countries have started 16 years and above, but when we look into the data between 16 and 18 years, there were no data available, but the data was extrapolated from 18 years and above. However, the registration, the conditional registration given to the companies, they can continue to submit the data to us, a rolling submission. More importantly is that at the moment, there are trials being done for 12 years and above. So if we have enough data, then probably we will perhaps adopt the strategy of 16 or even 12 years and above. So now the phase one will start on the 24th of February until April 2021 for the healthcare workers and the frontliners. And phase two mainly for the high risk group, looking into those aged, elderly, as well as those with comorbidities. We anticipated about 9.4 million people. Phase three will be for 18 years and above. Phase four will be for workers, certain groups of in the community that we need to focus on. So this is our policy, is paid by the government, but it will involve everyone in the country, whether it's local or foreign workers as well. So I think that is our strategy. No one is safe until everyone is safe. So this is why we need to look into even undocumented migrants or documented migrants, they will be vaccinated as well. So looking into the daily trends now, globally, we are seeing a decrease in cases, a declining trend in the US, in UK, as well as India. Why we are not very sure whether it's under testing. Oxford Martin School reported as under testing, but we believe that the strategy have changed probably in US, in UK. One is because they're following the SOP, putting on a mask, hand washing, and social distancing. Second is perhaps because of the lockdown that it be implemented in UK, and we are seeing a trend, a declining trend. Third, they have started the vaccination in December, so perhaps there will be some effects from the vaccination. But having said that, I think most important is in UK, for example, at the peak, we are seeing about they are seeing about less than about 10,000 cases. So this is a good sign, and we hope that we will also able to decrease or control our cases. And it's not impossible now with a double strategy of public health measures as well as the vaccination. We hope for the best that we are able to see the light at the end of the tunnel, and perhaps this is these two strategies adopted will be the beginning of the end of this pandemic COVID-19 in our country. With that, I think that's about and the post-pandemic. The nation's preparedness must be constantly enhanced from time to time. So whatever we do, we must be prepared. Adoption of a whole government and whole society approach, a policy decision based on facts and science while balancing lives and livelihood. Agility in decision making, administration and organization, public and private partnership continues to enhance from time to time, and optimization of new technology and ICT. I think this is something that we have learned from this pandemic. And if we can learn from the past and then prepare today at the present for the future. So the future is for us to prepare ourselves, and whatever experience that we had, this is important for us to prevent and also to adapt to the new future of outbreaks of infection in time to come. With that, thank you very much for the time and the opportunity to share the experience of pandemic COVID-19 in our country. Thank you.
Thank you very much, Tan Sri. That was an amazing presentation. Thank you very much for the informative presentation. Excellent slides. Truly a privilege to hear from Tan Sri himself, who has been battling COVID since day one, if not day zero. And it was very insightful to see the pandemic through your eyes and through your viewpoint, Tan Sri. Thank you. At this juncture, we do have some questions which we would like to pose to you, Tan Sri. Tan Sri, what do you think will happen post-vaccination in Malaysia? Will everyone start demanding a COVID passport to allow them to travel around, stay at hotels, go to the cinema, eat at restaurants? What is Tan Sri's view on that?
Thank you very much. So certainly, I think vaccination is a hope, delivers hope to all of us. But it's too early for us to make any decision whether the vaccination will be our immunity passport to travel around the world, for example. So I think the first thing is that let us get vaccination going. And then we would evaluate from time to time in terms of whether we can ease the restriction, for example, quarantine, or even looking into the data in time to come. Today, data probably we have 8 months or even 1 year to a maximum of 2 years, 1 year data to show that the efficacy as well as the safety of this vaccine. But the question is, whether we need a booster or whether the immune response will continue after 1 year or 2 years. So I think there's a lot of questions unanswered at the moment, but we hope for the best. Certainly, this is the key. It's not impossible. I think looking into the beginning that, but most important during this period of time, the transition period, although you've been vaccinated, but you still need to comply to the SOP. That means you need public health measures as well. So it will give us the external protection and also the internal protection. So this is the best strategy, external and internal protection. So we hope that until we are very sure that the internal protection is the excellent defense, then probably we can actually look into the immunity passport again, and we will discuss this with our colleagues as well as in World Health Organization.
I guess the best thing would be to never forget the 3 C's and the 3 W's. Vaccination, no vaccination, life has to redefine itself with these C's and the W's. Yes, Premila.
Thank you. Thank you, Dr. Sri. So Tan Sri, I have a question, I think from the student's perspective. In the UK, students in clinical years are prioritized as healthcare workers and essential service frontliners in the National Immunization Program. Will this be the case in the Malaysian context?
Well, we have 3 phases of implementation. The first would be for the healthcare workers, those exposed to the positive patient, for example. So our priority is among them, the healthcare workers, first is the vaccinator. So the vaccinator have to be vaccinated first. Second is those working in ICU or even in COVID ward, then they have to be given the priority. And third, I think the first phase is mainly for protection of the frontliners. Second, we are looking into vulnerable population. So we need to protect them, the elderly, the comorbids. But the third phase probably will start somewhere in May or June. Then is for everyone 18 years and above. So medical students will be given as well. So the only question is everybody wants to be in the first phase, right? That is the challenge. So we cannot have everyone to be given the first phase. At least we give the vaccinator first. So this is our priority. Once we have done that, I think rest assured, I think the government will give the vaccine to everyone in this country.
Thank you, Tan Sri. I think it's quite relieving to know that that they will be involved in, they will get their vaccine. Medical students will get their vaccines by May, hopefully. Thank you very much, Tan Sri. Dato Sri, over to you.
So, Tan Sri, Malaysia, as we all agree, has done a fantastic job in combating COVID-19. We've successfully brought down the RT. This to be the third time we're sort of bringing it down again. How has the MOH strategized in handling the equally important, everyone's worried about the non-COVID aspect of healthcare, that we might have ignored the other non-COVID illnesses in the fight against COVID? What does Tan Sri say to that?
Thank you. Well, if you look into the strategies, we have done our part, but we cannot win this war against COVID-19 if we do not have the collaboration and cooperation from the public. So again, we can bring the numbers down, but if the public start to, do not adhere and comply to the SOP, then it will go up again. So it's going to be a cycle catch-22 situation. So we are worried now when we look into the non-COVID cases. So what we have done is to optimize our resources. That we already started this on during the second wave, whereby we work with the private hospital. And the non-COVID cases, I think we referred them to the private hospital. No issue, because the government have allocated funds for us to send our public patient to the private hospital. And the private hospital have no issue accepting non-COVID cases. COVID cases probably they think twice, but then non-COVID cases, I think they accept it. So I think this is a good partnership done. So far, we have sent 46 illnesses to the private sector. For example, for angiograms, for bypass procedures, for AVF, and etc. So we have actually done that. So we'll continue to do that. And we also need to optimize our hospital and the resources. In terms of the manpower, equipment, and now we have this hybrid hospital and also a fully COVID hospital. Now, I'm happy to say that the private hospital has come on board with us. They have 2 COVID hospitals now and offered us more than 1,300 beds with 90 ICU beds. And total, we have 210 private hospitals, 130 we have identified that they have capacity, internal medicine, etc. And 105 already agreed to accept COVID patients. And the rest are still training their staff as well as upgrading their facilities. So I think you can see that the public and private coming together to address the issue of the healthcare. And more importantly is that we are also venturing into using technology to manage our patient at home. So diabetic patient, hypertension patient, you need not come to us, but we can manage you at home. So I think using technology for non-COVID patient is equally important. So we started virtual clinics and etc. But to some extent it can be done. But if you have to come to the hospital and clinic, then we can actually manage them well. We prepare them in terms of appointment system, etc. So I think this is how we can adapt to this pandemic to make sure that our services can improve from time to time.
Yes, it's great, Tan Sri, seeing everyone, public and private, putting their arms together to fight this pandemic. So, Tan Sri, it has been truly an honor to share the same screen as a luminary as yourself. at least not the same stage, but same screen in this post-COVID era. And Tan Sri truly has been on the ball with the virus from day one. I should say you've handled the pandemic like a true surgeon and clinician. Evidence-based medicine and very clear, incisive directives. So all this has truly helped the Ministry of Health and Malaysia as a whole. And coming from the state of Perlis, where like all Malaysians, we did faithfully institute every recommendation. We actually enjoyed a spell of being green for some time. So probably this goes to show, as you said, Tan Sri, that the policies and directives that have been issued by the MOH are effective when implemented and enforced. As Tan Sri has mentioned, this fight belongs to every Malaysian. You are leading us into the battle, but we must fight. So at this point, I'd like to echo the famous words of Napoleon, who mentioned, if you give him an army of 100 lions and the leader is a dog, in any fight, the lions will fight as a dog. But if you give him an army of 100 dogs, and if their leader is a lion, then the dogs shall fight as lions. So we will fight like you have been fighting, Tan Sri. It is upon every Malaysian to be in this fight together. You, Premila, me, everyone on this webinar, everyone in Malaysia, all of us have to do our part. Thank you very much, Tan Sri, for taking time out to deliver this keynote address. If we haven't said it enough, Malaysia thanks you for your tireless efforts and sleepless nights, and Malaysia is truly behind you, Tan Sri.
Thank you, Tan Sri.
Thank you very much. Together we can make the impossible possible, and we're here to find common solution for a common problem. So we hope that we can work together as a team for the country. And again, I'll take this opportunity to thank NewMed for organizing this webinars. I hope that it will benefit those listening to this webinar. Thank you very much.
I do hope you have found that speech by Tan Sri truly engaging and informative. Up next, the plenary session on advanced acute internal medicine at 10:15 a.m. Please stay tuned. back, ladies and gentlemen. For those who have just joined us, a very good morning to you. Advanced acute internal medicine has been identified as the future of healthcare service, covering a broad spectrum of clinical work in a range of expertise, including immediate management of life-threatening emergencies and early treatment involving general medical ailment. Who best to speak about this but the royal patron of the Malaysian Advanced Acute Internal Medicine and Ultrasound Society, Duli Yang Teramat Mulia, Tuanku Said Faizuddin Putra, Raja Muda of Perlis. Tuanku will be addressing the advanced acute internal medicine and the role of physician-led ultrasound and echocardiography in medicine in this pre-recorded session. This will be followed by a plenary talk entitled Advanced Acute Internal Medicine, the Paradigm Shift by the Malaysian Advanced Acute Internal Medicine and Ultrasound Society. Speaking on this topic are Dato Dr. Noel Thomas Ross, the National Head of Acute Medicine and the National Deputy Head of Internal Medicine. Dato Dr. Thomas also holds the position of Deputy Head of Department of General Medicine, Hospital Kuala Lumpur. He will be joined by Dato Sri Dr. Paras Doshi, a consultant physician of acute medicine at Hospital Tuanku Fauzia Perlis. Dato Sri is the president of the Malaysian Advanced Acute Internal Medicine and Ultrasound Society. He is also the vice president of the College of Physicians Malaysia and the national coordinator for the postgraduate training parallel pathway. Ladies and gentlemen, at the end of this session, you will be given an opportunity to ask any questions that you may have. Please include your questions in the Q&A box and the speakers will try to address these questions.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and salam sejahtera. The best preparation for tomorrow is the right use of today by Terry D. Ladies and gentlemen, the SARS-CoV-2 pandemic taught us that preparation today is true of paramount importance in dealing with the problems of tomorrow. Our previous experiences with SARS and the MERS-CoV epidemics serve us well in planning our subsequent responses. Our services and manpower were stretched in dealing with this COVID pandemic. Physician-led services in combating this virus were required in almost every corner of the country. In addition to COVID, the Ministry of Health also had to look into dealing with these non-COVID services and ensure that they were not left out. Non-communicable diseases, if not properly addressed, had the potential of resulting in increased mortality as well as overloading the healthcare facilities after the waning of the pandemic. The stress that was placed upon the healthcare system taught us that we truly need more physicians. We need physicians who can cater to the needs of the country. Physicians who can cater to the needs of the patients usually require a multidisciplinary approach to their multifaceted problem. Physicians who can handle a patient holistically and not just restrict themselves to their niche domain or areas of specialty. Ladies and gentlemen, clinicians based in Malaysian hospitals are seeing and managing ever greater numbers of patients who present with acute complex care needs, which do not necessarily fall exclusively into a particular subspecialty. However, there are a number of occurrences where the subspecialty medical workforce did not manage to address the needs accordingly due to their limited expertise in the particular area. Such occurrences could lead to misperceptions on problems faced by patients as well as medical needs of the Malaysians. As such, it would be best for these complex, undifferentiated patients with COVID to be left under the care of clinicians with different general skills instead of those specialized in single-system pathology. A clinician with more general skills and an ability to work in a multidisciplinary team is critical to serving the needs of the country. Ladies and gentlemen, the future of general medicine or advanced acute internal medicine in Malaysia and other countries like the UK and Australia has received a lot of exposure in recent years. We have the advantage that we can learn from the experiences of the healthcare systems in these countries. While they may serve different populations, many parallels can be drawn between us and them. It remains difficult to define the exact patient population best catered by this versatile specialty, which is probably a pleasantly reassuring testament to the wide range of the specialty. This also means that the potential for AAIM to be used to great effect in solving perennial hospital issues like patient access block or even over the investigation in patients has yet to be utilized. Hospitals like Hospital Tuanku Fauziah are representative of many of the smaller hospitals. I aim to ensure that we can train as many AAIM physicians to serve these areas where the care is truly needed. AAIM subspecialists will be a game changer for our local hospitals. Due to their extremely wide scope, they will be guided to develop one-stop physician-led services, which will dramatically improve the level of care being delivered to patients by catering to some specialty services under one roof. For extremely niche input, the patients can be referred to the relevant specialties. MAAIMUSS, Malaysian Advanced Acute Internal Medicine and Ultrasound Society, in keeping with the changing landscape of COVID, had pioneered a unique online ultrasound and echocardiography course that combined online teaching in the form of interactive webinars and local hands-on training from trained supervisors within local hospital setup itself. This was an especially opportune moment since the movement and gathering restrictions made previous methods of teaching in big conferences or meetings impossible and even dangerous. Yet the course of training our physicians in these critically important skills had to be continued. I'm happy to note that the first phase of the course was a resounding success and was heavily oversubscribed. It had been received interest from physicians outside of the government sector and even from other countries like Singapore and Brunei. At this juncture, I appreciate the cooperation of the Ministry of Health and Newcastle University Medicine Malaysia in helping to champion the cause and spread awareness of this fledgling specialty to all doctors, including the budding ones who will be the doctors of tomorrow. Thank you very much. Wabillahi taufiq hidayah. Assalamualaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Junjung kasih Duli yang teramat mulia Tuanku Said Faizuddin Putra Ibni Said Sirajuddin Putra Jamalulail for enlightening us on your vision for advanced acute general medicine and the role of physician-led ultrasound and echocardiography in medicine, which is the paradigm shift by MAAIMUSS. Thank you very much to Ms. Premila, Provost Prof. Chris Baldwin, NUMED, and of course MAAIMUSS for getting us together this morning. Forward Malaysia, charting new paths to the next normal. A very good morning to all our webinar attendees. I'm here with my colleague, Dr. Noel Thomas Ross, who is also an AAIM consultant. Dr. Ross, would you like to tell them what we are doing for advanced acute medicine?
Yes, a very good morning to everyone. I'm Dr. Noel Thomas Ross. I'm actually stationed at HKL, where more or less AIM was first started. You can see where it was actually born. And I'd like to thank Dr. Aain for his effort to push AIM strongly into the subspecialty. Dr. Paras?
All right, so we both practice something that's new, advanced acute medicine, something that's exciting, something that's full of adrenaline. And I'm sure everyone in the audience is like, yes, we all love saving lives, but does it make money? All right, I think it does, yes, loads of it. But hold on, that's not the reason that we are supposed to be here today. We should not be here for that. All right, it's to learn, it is to advance our careers, and we all need to evolve in the useful elements of society. If the answer was still money, then I think we're in the wrong forum, but we shall do no harm. So first and foremost, let's show a video of how advanced acute medicine is supposed to be. All right, so this video will probably make it very easy for those of you who are not clear as to what it entails. All right, this video was done 6 years ago in one night. Yes, we doctors still worked hard those days, and we did not have fancy gadgets like the gadgets that you have here today. All we had was a simple phone camera and iMovie to recreate this. All right.
Saya sangat sakit dada, Encik.
Masuklah. Sila masuk dulu. Okey, Cik. Sekarang sakit apa?
Sakit di tengah, Encik.
Dah berapa lama sakit?
Baru hari ni.
Baru hari ni sakit kan?
Ya.
Jadi saya nak tekanan darah Cik ya. Dengan cek cek jantung Cik ya.
Okey, ya. Terima kasih. Doctor, please help me. I'm in deep pain. My chest is pressing me. I got diabetes. I got hypertension. I got cholesterol. I did angiogram recently. They say all are normal.
Chest pain, T inversions. It's gotta be ACS. I'll admit to medical.
Hey uncle, relax uncle. Where is your pen, uncle? Show me again. I'm not sure what he is having the pain. ECG. They didn't teach this me in this medical school. Maybe I was sleeping. How am I gonna solve this? I have to ask my friend how to do this. What is this? Now I'm stuck. Okay, maybe Sarawak handbook. Never mind. Call my MO. Or my MO is gonna catch on me and scold me. Doctor, this patient diabetic, hypertension, complain some chest pain. Now here is ECG law.
Oh man, not again. Another intern whose presentation I can't rely on. Must be an inborn matter of metabolism. So sir, tell me, you're having some chest pain? How long have you been feeling abdominal pain? The pain seems to be in his stomach. So it does get worse than spicy food. Let me feel your tummy.
Oh! Ayo, look at that. He caused so much of pain to the patient by pressing like that.
Boys and girls should never do this in MRCP exam. You're gonna get big fat 0 in your G welfare score and fail MRCP.
Stroking my beard makes me look smart, but I'm just itchy. I think I got it. This is gastritis.
Code 6, Ward 5. Code 6.
I think we need to refer for gastritis.
Ward 5.
Now, I need to call the gastroenterologist.
So this is the patient talking about. He's got some pain, eh?
Yes, he's the one.
Epigastric pain, eh? But did you do a PR?
No, I didn't.
Man, you gotta smell it. You gotta smell it. You gotta smell it. He's gotta put a finger in. He's gotta check a PR, but he didn't do that. So, do you have any diarrhea? Listen to me, boy. We gotta scope him. Can you do that?
Okay.
Quickly, all right? Don't waste my time.
Yes, sir.
Doktor, ada patient bukan marah untuk
Kanan.
Hello. I'm calling from the first class. I need a scope appointment quickly for one patient.
this is full lah. 20 scopes full.
I see. Berapa lama lagi kena tunggu ni?
5 RCP full today. Bronchoscopy also full.
Ladies and gentlemen, if you find your house officers sprawled on the floor like this, do not, I repeat, Do not attempt CPR. He is not dead. He is just waiting for a scope appointment.
One fine day, my poor hardworking gastro will scope himself by mistake.
At last, I got the scope appointment. My MO is going to be brought me. Wah, sugar so high, huh? Creatinine, renal failure. Wah, it's pening kepala lah. Prefer endocrine lah.
So, who are you? Are you the MO? Are you calling to refer a case? Diabetes. Okay, tell me the BMI. Waist circumference? HbA1c? Nothing you know. Fine. If you can't find the information, find out, and I'll see the patient in 2 weeks. Bye.
Why you call me? Hi, always disturbing me. Renal failure? What's the creatinine? Do you know the creatinine? Has also KUB been done? Why do you refer to me with ultrasound KUB? Oh, you get the KUB and then you give me a call, okay?
Doctor, I need the ultrasound KUB urgently, doctor. Please. This is the bed. This Aain is the mountain. This is ECG. You know, this is not a heart problem. This is a stomach problem. Did you know that? Are you sure? All right, because if you didn't know that, I'd have to get you extended. Did you pass your Viva? All right. I need him to get a scope done. Quickly. All right. Boss, his sugar is very high. Morning, eat so much. Lunch, eat so much. Dinner, eat so much. No problem. His creatinine is very high. Oh, okay. You have problem with your urination, your prostate maybe? How's your urination like? Okay. Wow, last time, damn good. But now, कभी खुशी कभी कभी खुशी. Seems like an enlarged prostate. I think I need to check the size of your prostate. You didn't do a PR. Why you put a jelly on me? I should have warned you about it.
Okay, here we go. Once we did the scan for you, we noticed that your prostate was enlarged. You need to visit the urologist. Not to worry, they'll take care of you.
From the first moment I saw him, I knew there's nothing wrong with his heart. For first thing, his ECG was normal. There's something wrong. Second thing, his gastric pain was pronounced from eating earlier. So I knew I had to do an ROTS for him. So ultimately, after the scope showed forestry ulcers. What else did I do? I corrected his diabetes in the ward, and then for his kidney problem, and then ultrasound. He has prostatomegaly. And just like that, it's elegantly what's it.
Get it right the first time, that's the main thing. Gonna make a first time list. La 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 la.
All right, I hope you enjoyed that video just now. So advanced acute internal medicine deals with the best and the most interesting few hours of a patient's admission, which are basically the first 72 hours of an admission. So advanced acute internal medicine basically is the hospital specialty concerned with the assessment, diagnosis, treatment, and of patients with urgent medical needs. It's formally recognized as a specialty in 2009, having previously been a subspecialty of general medicine. So what do we do? Yes, Dato.
I'm sorry, Dato, I can't see your slides, like your slides.
All right, can you all see the slides now?
Yep, can. Yeah.
Okay.
So what do we do in acute internal medicine? Okay, it's a hospital specialty actually, where we do assessment, diagnosis, treatment of patients with urgent medical needs. Formally recognized as a specialty in 2009, it was previously called General Internal Medicine or GIM.
So what do we do basically?
What do we actually do?
Yes, Dato.
Okay, what do we actually do? We do clinical work within the specialty with immediate management of life-threatening medical emergencies, initial treatment within the first 72 hours.
There's also a focus on basically recognition and management of acute medical emergencies in previously stable patients, and also development of pathways for patients who do not require immediate admission. So what do we learn? Yes, Dato. What do they learn?
Okay, basically what we learn in acute internal medicine is we put it through a lot of postings, okay, where you learn specialist skills. Okay, this is the core of the training of AAIM, all right? Practical skills such as echocardiography, ultrasonography, bronchoscopy, and OGDS. Okay, you can also gain qualification in management and leadership education.
So where are we based and what do we do? We are basically hybrids. We work like the acute medicine physicians in the UK, and we also work like the hospitalists in the US. So basically we're a hybrid and we do both of what these people will be doing in their respective healthcare systems. Plus, we also review outpatients, both new and follow up the ones that have already been seen from before. So basically we are a hybrid that manages patients both in the system and out of the system. So that how many do we have now? So we are like the Avengers, isn't it? All right,
Yes.
all over. All right, we have to play all the roles, and of course we don't look as good as Iron Man and Captain America and of course Scarlet Black Widow. But yes, we basically play many roles wherever we are required. We are still in the teens. We are growing in numbers. So acute medicine is not exactly new. All right. So we have luminaries like Dr. Chris Young, Dr. Ngao Gen Yu, Dr. Letchman, Dato Kauterman. So this is like the Avengers, they have their chief at the top there, Nick Fury. We have ours, Dr. Letchman. I hope you can see the resemblance there. Yeah, it looks pretty similar. And of course, Dato Thomas, he's our new Nick Fury. So yes, he still has hair, whereas Nick Fury doesn't have hair. So basically, these are our bosses for advanced acute internal medicine. We basically go wherever we are required and we fit into the role that is needed. So Dato Thomas, where are we placed right now?
Okay, like you can see in this map here, we are actually mainly concentrated still in West Malaysia, and that also the West Coast. All right, so there are actually about 19 of us now. 13 have already completed training, and there's another 6 in training. So we need to plan to get people in East Malaysia and also in East Coast of Malaysia.
All right. So how can we make a difference? So we are like Steven Gerrard. Everyone knows Liverpool. Steven Gerrard can play in the center. He can play in the midfield. He can take Lucas's position. He can take Skirtle, center back. He can be up front. He can be Johnson. He can play in whatever role you want. So we are like that as advanced acute internal medicine physicians. We basically fit into the role that is required in that healthcare center. So basically, we become utility physicians. We can play in whichever role that's required, and we basically suit the healthcare needs of that local hospital. So a super physician will then be able to go out and set up the specialized services, even if you do not have gastro or nephro services there. So where do we work right now? So we can work in an AMU, MAU, MAPU, HDW, or a general medical ward. We work best within the acute medical unit, and we also can work, yes, Dato, we also work very well in the high dependency units. Dato Thomas is based in the CCU, HDU, and HDW, and also in the general medical wards, where we actually help in bringing down the length of stay. So Dato, what's the big deal about ultrasound? So basically, yes. So basically, it's been proven to be superior to chest X-ray and pneumothorax, and basically it can pick up where chest X-rays are not able to pick up, and it allows confirmation of consolidation versus effusions and also ultrasound guided tapping. Does it make a difference in the wards? Dato, would you like to tell them on your experience?
Yeah, okay, it makes a big difference in the ward because it allows instant diagnosis. We all here, we are running short of beds always in the general medical ward. So you can make instant diagnosis. You can diagnose obstructive nephropathy, okay? And you can also pick up things like liver abscess and hasten the diagnosis and management.
And also DVT, yeah, it really helps. So many patients, we're waiting for a scan in the wards. We actually scan them, we're able to pick up the DVT and send them home with the Clexane. So we can also look at acute versus chronic heart failure. Hypokinetic regions is in doubt. So that's Dato Thomas's area. And Dato, yes, post-MR, isn't it? Post-MI, we can pick up the MR or cardiac tamponade, and also volume status. We can look at scanning the IVC. So Dato, what else can we do?
We can also do a diagnostic OGDS. Okay, can be performed if you need bronchoscopy, especially in patients who have got lung collapse, where there's mucus plugging. You can just do a bronchoscope and suck out a mucus plug, and it makes a hell of a difference to the ventilation. And above skills are actually done at great speed. Okay, it hastens the patient's diagnosis and reduces the LOS, length of stay.
So we can be stationed in the emergency department as part of a mobile team where we move. It helps reduce the waiting time for the patients to get in, and we can discharge from the emergency department itself. All this makes a difference in reducing the length of stay, and we also change the diagnosis for certain cases to go to the other specialties. We can also be stationed at the rapid review clinic where we review the patients the same day or the next day. We review them early upon discharge as well. And all this helps reduce the length of stay, especially with COVID. So Dato Thomas, can you tell us about imaging at the bedside with ultrasound?
Yes, basically now I think many hospitals have already got bedside ultrasound. It's called the Lumify, okay, where you got 3 different probes, one for vascular, one is for sector probe for the abdomen, and the other one is for echo. So it actually basically replaces the physician's stethoscope. Basically, rapidly you can make diagnosis even before the X-ray is there actually. And you can see these x-rays can be quite confusing at times. You don't know whether the patient is having a COPD or heart failure or pleural effusion with collapse, or is it pleural effusion with pneumonia. So ultrasound really makes a quick diagnosis in these cases.
That's right. So these are states that coexist together. It makes it difficult whether it's sepsis, effusion, collapse. So for that, we've now created a society, MAAIMUSS, all right, which basically talks about advanced acute internal medicine and ultrasound society. We had a course last year whereby we actually had hybrid training, whereby we trained the physicians online with a webinar, and we also facilitated hands-on training. And probably this is the way forward, isn't it, Dato', right now for advanced acute medicine, training online.
Exactly.
All right. So we have a few questions, Dato'. They are asking what's the difference between AAIM and regular internal medicine? And what's the difference between acute medicine and emergency medicine, Dato'?
Okay, first difference between AIM and the normal internal medicine. In AIM, actually, you go through multiple rotations, okay, and you pick up skills. This is the extra added point. You pick up skills in upper endoscopy. You become fluent in echocardiography. You learn up lung ultrasound, which you cannot find in any other specialty, and you can also do bronchoscopy. So actually, you are equipped with skills which can make you diagnose conditions very fast. Actually, rapid diagnosis and rapid discharge of patients also. That's the difference.
All right, great, Dato'. Any other questions from the floor? So now hopefully they are aware of advanced acute internal medicine, and they are aware also about emergency medicine. Emergency medicine is very different. Acute internal medicine basically sees the amalgamation of all the specialties after the emergency department. All right. Okay, so that's all. We've answered all the questions. Thank you very much for your time. Thank you very much to NUMED and also MAAIMUSS for making this happen together. Dato' Thomas, thank you very much for your time again, and we hopefully will see more of you taking up this very important field that's necessary to shoulder the burden of COVID. If you have any questions, Dato' Thomas is our Nick Fury. Get in touch with him. He's in HKL, and if you have any questions on how to train for this new program, please let us know. We are very happy to take you all on board. All right, over to NUMED.
Thank you very much. Thank you, Dr. Noel Thomas Ross and Sri Dr. Paras Doshi on that insight into advanced acute internal medicine as the future of healthcare service. We will now take a short break and shall return at 10:50 a.m., where we have an esteemed panel of speakers who will be addressing the way forward, a strategic roadmap beyond COVID-19. morning, everyone. Welcome back. The COVID-19 pandemic is a global crisis of historic proportions. 1 year on, we have seen so much happening. Looking back on this day, no one, or at least the layman, would have thought that we would be facing the biggest public health emergency in modern times. What will be the new normal that emerges in the wake of the COVID-19 crisis? Joining us today in providing their insights to what is deemed the new normal, the COVID-19 vaccine, and most importantly, an update on vaccines are our esteemed panelists. First up, we have joining us Dr. Lechman Ramanathan GR. Dr. Lechman is the National Head of Medical Services and the Head of Medical Department Hospital Raja Permaisuri Bainon Perak. In addition, he holds the post of President of the College of Physicians Malaysia. Our next panelist is Datuk Dr. Mahiran binti Mustafa. Datuk Dr. Mahiran is the National Head of Infectious Diseases and a Senior Consultant Infectious Diseases Physician at Hospital Raja Perempuan Zainab II, Kelantan. Also joining us today is Datuk Dr. Suresh Kumar Chidambaram, Consultant Infectious Diseases Physician and Head of Medical Department at Hospital Sungai Buloh. Datuk Dr. Suresh is also the Chairman of the National COVID-19 Task Force. Last but not least, please join me in welcoming back Datuk Sri Dr. Paras Doshi, who will be moderating this panel discussion. Over to you, Datuk Sri.
Thank you very much, Newmed. Thank you very much, Premila, for the kind introduction. Thank you to our esteemed panelists for joining us today. It has been a great pleasure to share the screen with such esteemed doctors, and these are luminaries in their field. I believe some of them are already household names. It's indeed a humbling opportunity to hear from my mentors who have taught me and countless others. So thank you very much, webinar guests, for being with us on this Saturday morning. COVID-19, the key word for all of us today. As we all know, coronavirus 19 is not the first, and there will be many others. So we've had a lot of information coming to us on Zoom, on WhatsApp, on Telegram, a lot of information, and there's a lot of disinformation that's going around. Dr. Suresh, would you like to just quickly tell us what are we seeing right now in terms of the virus and the mutations that we have facing us?
Thanks. Can you hear me?
Yes.
Yes. Thanks. I think with world over, I think the infection rates are coming down. As you know, all over the world, the infection rates are coming down. It is part of it is bit of vaccination, but most of it is because of more awareness of social distancing measures that has been implemented. The second thing is, of course, death rates. The case fatality rate is coming down. Part of it is because we now know better how to manage the hyperinflammation phase in COVID-19. But still, all of these are very much dependent on social distancing measures that we have to implement. But the social distancing measures cost the economy a lot. And so people talk about lives versus livelihood. And the challenge now is whether we could go on and bring in a huge amount of vaccination, drive through, so that we can bring the livelihood back into forefront. With regards to the various strains, it's an evolution. But viruses always mutate. I think the three strains that I can think of, the one that is in UK, which we now know increases infectiveness, but most vaccines work for this UK strain. There's also a South African strain, which is a bit more worry, because some of the vaccines don't work very well. But the vaccines that we use still are effective in preventing hospitalization. So all the vaccines, whatever strain, are effective in bringing down hospitalization. But some strains, like a South African strain, I think some vaccines are not effective enough to prevent infections. We still have to wait and see whether the huge vaccination drive that the whole world is going to go do will drive the vaccine towards producing mutant strains that makes the vaccines ineffective. We'll have to wait and see.
True. A lot of information actually going around also on treatment options for coronavirus. Lots of funny theories that abound: hydroxychloroquine, bleach, blah, blah. lots of things that are happening. But Dato Mahiran, all the way in Kelantan and also head of infectious disease, what would you like to say to our doctors who gather today if the important points regarding treatment of COVID-19?
Okay, as far as we are concerned, treatments or management of COVID-19 cases are actually evolving. So you really have to be on the guard that whatever you give now with minimum evidence base, I would say, because of rapid resolutions and evolution, then you really need to change your treatment guidance based on the latest updated evidence. It's not like that's what I feel, that's what our consensus are. So it is really made us work like, you are learning every day. There will be new publications on treatment. Hydroxychloroquine was thought to be one thing that was great for the early case, So at the end, it was nothing. So it was actually excluded. Now comes with so many things, and people are looking at the importance of management of COVID is not at the very beginning, not part of the viral phase, but actually is in the middle between the end of the viral phase and the early part of inflammatory phase that we could actually detect, then start early treatment with the drugs that has minimum cost, highest benefits, and less side effects. Because there's so many drugs that even anti-inflammatories now being published. For example, for antiviral ivermectin and so on, we actually still at the early phase of learning and try to get more information before we actually embark on our patients. So these are the things, it's like weekly we have to review the whole lot of journals, publications, and see what's best to our patient. Whether anti-interleukin 6 will be the best, whether it's just steroid to be the sufficient for severe cases and so on. And if steroid, what kind of dosage and how to actually deliver the steroid to the patient. Other drugs, for example, supplementary vitamin C and so on, there are many studies, but it's small studies. And usually it's very difficult to actually apply this kind of practice in our country as a whole. We're still waiting for more result from this kind of supplementary IV vitamin C and so on. We need more data for that. So as a clinician, it is on guard to find the best medicine that can give the best outcome in terms of hospitalization, reduce the severity, and also reduce death among our patients. That's our aim.
Okay, so do we take young house officers? Should they take zinc, vitamin C for patients who have been diagnosed? Is it something that we take as a prophylactic or better not to?
So far, I won't advise that. So far, 80% of our patients actually recovered. Whether you take prophylaxis or non-prophylaxis and so on. So I think the big chunk actually they recovered. Only if we manage the targeted populations who are actually vulnerable to progress, I think that's our target to prevent the deterioration in this high-risk population. Not if you look at even our mortality, death less than 40 years old is very, very low compared to those above 40, 50, especially our demarcation. I think Suresh had the data on that. And those with comorbidities are people who will actually progress in terms of severity and will not do very well once they are ventilated. And these are people whom we need to concentrate, not the prophylaxis. Prophylaxis is non-pharmacological one. I think by the 3 C's that we actually ask people to adhere, if people can adhere, then at least 30% of the risk they will not actually acquire infection. And you have another 30 to 40, another 50% from the vaccination that we plan. So you end up with having 90%, nearly 90% protection about acquiring the transmission, reduce the transmission. That will help the general public. So you don't need drugs to actually have as a prophylaxis.
So Dr. Suresh, any input on treatment regimes also that are being employed in Sungai Buloh?
I think nationally we have got a consensus on how to treat COVID, and so for the antivirals we use favipiravir, more effective in the first. We think it's more effective in the first 7 days of illness, and then subsequently when patient has evidence of inflammation by rising CRP and hypoxia, we give steroids, and then subsequently, if steroids don't work and the patient still shows evidence of inflammation, we try tocilizumab. I think the treatment protocol wherever you are in the country now is fairly standardized, and that's what we do. A combination of antivirals, steroids, and IL-6 inhibitors.
True. So Dr. Lechman, COVID-19 has been unprecedented in terms of a crisis for the country. The impact upon hospitals, COVID, hybrid, non-COVID, all have gone through a pretty much seismic shift in terms of manpower and resources. Probably a nightmare right now as a head of service for internal medicine. So how was it in your mind? How was it handling the resources, the manpower, the logistics, people falling ill, people asking for doctors? How was it from your side?
Thank you, Dr. Paras, for the question. Epidemics has occurred before. For some of us, we went through the SARS first epidemic, I think it was in 2003. So there is some experience. We didn't start from ground zero. Of course, this time the sheer numbers many more times higher. So the challenges were more. And I think the Ministry of Health did the right thing by having a national body with guidelines being sent out to state level, and then state levels also had their committees looking at it, and then to the various hospitals and identification of hospitals that have taken COVID early. So all that was done as the epidemic was progressing, and we had to make changes as it came. As National Head of Medicine, well, there were moments where help was required in certain hospitals, and then we mobilized our specialists as wherever we could. The fact that we had, we know who was where helped us, so we knew who to move and where to move and where the shortfall was and who could spare the extra pair of hands. And on the local scene, the ID physicians led the actual management in the hospitals. And where there were not ID physicians, then whoever the internal medicine specialists, they are physicians, they will then take the lead. So I think this is one area where we cannot be looking at specialty and subspecialty. I think whoever is on the ground needs to do the job when needed. Your basic training should allow you. Of course, a lot was said about AIM this morning, and I suppose if you had more AIM physicians all around the country, it would have helped as well, because you would have a broader to respond to the situation faster. So yes, it was an experience. I think rather than say why this is happening to us, we should be looking at it as an opportunity to learn on the job as we are doing it. And I think we did that. And this would augur well for the future as well. Yeah, thank you.
Thank you, Dr. In terms of Dr. Suresh and Dr. Mahiran, what are the presentations right now, and what are the complications beyond the usual COVID that we are seeing?
Are you talking about the acute COVID or post-COVID?
Probably the complications that we need to look out for in acute COVID, and a lot of people are now talking about long COVID and things that we don't usually think about. So, what is it that we should always keep in mind?
Yes, you know, when even at the beginning of the pandemics, I think nobody actually knows the whole stories about COVID-19, right? And many thought that it will just be confined to respiratory pneumonia, respiratory illness, and pneumonia. Then suddenly people thought about, you know, hypercoagulable state that may affect other organs, and you may actually have, you know, pulmonary embolus, you have stroke, you have cardiovascular event. Once you have COVID, these are things outside the acute COVID per se, but the impact on the coagulations and impact on the end organs affected. So it is not about pneumonia only. The second one, now you start learning about post-COVID acute illness that can be long after the COVID recovery. So you may have, you know, it's just like a chronic fatigue syndrome, I would say. You know, you get fatigue, you get myalgia, you have sleepless night, you know, your memory span may be affected and so on. A lot of things, you know, it's been seen that even people documented even up to 9 months to 12 months. So this part of long COVID, we have not actually really document and see how bad actually it is within our own population, but it's been, you know, written in the publications and so on. So I think what we actually start to try and do is to look at, you know, acute COVID per se as a complication of it. And the second one, we are trying to do audit on those who actually been discharged well, supposed to be recovered from COVID, you know, day 10, day 14, or day 21, or day 28 from ICU, whether they actually had come back to the hospital, you know, within a short term. For example, 1 month, because during the early part, we start seeing that people with COVID come back within a week, 2 weeks after COVID recovery for MI. But these people are also the high-risk group. So we're not sure whether it is fully related to COVID or whether it's just part of their IHD manifestation, the risk of going to have MI during the stress period or so on. So somebody texted me yesterday whether we have data on long COVID, you know, in Malaysia. I would say that that's interesting. We may actually look in among ourselves, but I think we have to probably gather some of the work as well from the family medicine specialists, because these people actually might be attending their clinics actually for all these symptoms. They will rarely will come with these symptoms to the hospital, you know. So we will probably sit down and form a committee whether we would actually do some surveillance on this long COVID. That would be nice to know what's actually happened in our community rather than just see, you know, it's happening in US, it's happening in other part, even in China, that's been published until last month. So we will sit down and probably start doing the surveillance post-COVID complications and surveillance among our patients. So, but how to go and do it? The problem with us in Malaysia and Ministry of Health is that the manpower, where we are busy, you know, managing the acute infection, we need people who can actually do some work on this part, you know, post-COVID recovery, surveillance, and long COVID. So, but I will propose to the Ministry of Health and see whether, you know, they can form a committee to look, and this can be even, you know, general medicine, FMS be part of the surveillance team.
It will need to be a massive exercise
to know our peoples. Huh?
Sorry? Okay. This will need to be a very massive exercise to get public health in, and for house officers, they all will be the long COVIDs, and as you mentioned, they may not really be aware of the complications. So the complications we see for long COVID, besides chronic fatigue syndrome and lethargy, MIs, anything else that we are seeing as well, Dato' Myron, Dato' Suresh, any other complications they need to be mindful of?
So I rasa, these are the common symptoms they would have. But since they actually normally would go to the clinic kesihatan or GP or private practitioners, we do not know actually the magnitude of the problems in our people. So we're not sure, they don't come back and see ID people. So in our guidelines, we say those with high comorbidities, for example, diabetes, COPD, and so on, we suggest that within 1 month of their discharge, they should go and have a follow-up. But beyond that, we didn't have any advice on anything. So just at that time, we were just looking at to see their stability in terms of their comorbidities, 1 month post-discharge. That was our recommendation once they are discharged. But, beyond that, we do not know because we don't have the surveillance systems.
I liked your line, they don't come back and see ID physicians. They probably go and see their tok batin, go and see the bongo, rasa lengo, say hi. They're probably the last thing on their mind is to come back and have a word with the ID
they won't
physician.
come back to the COVID hospitals. I want to add on Dr. Lechuman regarding our hybrid, our COVID-19 hospitals and also non-COVID, because this, when we actually prepared the guidelines, we actually prepared for an outbreak situation for the country. So it's already stated, and then we actually listed down those hospitals who will manage this outbreak of unknown pathogens. So we thought it was not going to be as big as this pandemic, So we listed that hospitals with mainly ID would actually manage the infected cases, even for unknown etiology, for any infection. So that's one. And then there's another hospital which we didn't call hybrid, is the hospital without, not major hospitals, but hospital like, for example, district hospitals and other hospitals are only hospital that would investigate, get samples done and so on. But once confirmed, they will go to the non-call hospitals. So, but at that time, we were actually having problem as well when we said that there are infection that may need isolation like this. And I think you all know that our hospital in the government has very limited numbers of isolation rooms, cubicles. Most of the hospital, the old-timer hospitals are open space, right? Even HKL, and so not many, very isolated. It's very open between the people walking at the side of cubicles. It's very open cubicles. So very airy, good ventilation. But if you don't mix the patient, it's okay. But once you mix the patient, the one pending result, the one confirmed, the one, not included as under possible or suspect cases, it will be a problem because the ventilation is actually mixed. So actually, to label hospitals with this kind actually is very, I would say, it's quite dangerous as well. But now I think we start making the hospital division, the planning division, to actually understand our wish, and we go towards a safer hospital to cater if there were another outbreak like this. So new hospitals who actually in the midst of designing will actually have better facilities to cater for cases like this. And hope one day, it may not be my time, but it may be Suresh, in 5 years time, 10 years time, we have more hospital that can be labeled as hospital to manage infectious disease outbreak, but with the actual facility, a better facility for a safer environment for patients, staff, and even for relatives who accompany the patient. I wish that it will happen, you know.
So thank you very much for your viewpoint. Dr. Lech, would you like to comment and add to that?
I think once a diagnosis is made, then of course we need to have the isolation facilities, as Dr. Aain has pointed out. But as healthcare workers, and we will always be exposed to infection diseases all the time. And we have always been exposed, and we will still do so in future. I think in retrospect, those who went through SARS, at the period of SARS in 2003, many of us said, look, we need to change the way we work, the way we admit patients, the way we put them in a certain area first until we get the diagnosis. All that ideas were there, then SARS died down within months, and no major changes happened across the world. I think this time around, it's another call for us to relook at how we have a pathway for patients who come with especially respiratory symptoms. And we do not know what they may be carrying, and we will not know when the next new pathogen comes about. No doubt the last one, major one was, 2017, 18 years ago. But, in between we had H1N1, we had MERS go. So this will keep repeating, and there won't be a definite timeline when to expect it can happen anytime. So I think we need to also take note that we cannot have the perfect buildings, hospitals everywhere overnight. As Mahiran says, the plan for new hospitals, yes, that is, I think Mahiran and the team has put up a proposal for that. But what about the ones we have at the moment? How do we can adapt, take into account? I believe that if hospitals have a good sort of a laminar flow in the ward, that means there's windows on both sides, and there's enough space between patients, that would also reduce the degree of infection between patients if it happens. I worry about enclosed areas, aircon areas where the air is recirculated. That needs to be relooked the way some hospitals has been done. And I think either we put a HEPA filter or we do not recirculate the air. These are things that need to be looked into immediately in the hospitals that we have. Thanks, Faraz.
Very true. Very true. We are in a sticky situation. We have to make do with what we have. But I think the pandemic has shocked us all. And as Dato' Mahiran has mentioned now, I think we will take note. And I think the powers that be will also take note that moving forward, hospitals have to be redesigned to take into account these respiratory pandemics from the word go. Dato' Suresh, a common complaint that people always have is, are we testing enough? What is pooled testing? And now we are only testing close contacts. Sticky situation. What advice do you have right now?
Yeah, I mean, it's very, as you pointed out, it's very, very difficult to decide are we testing enough? And some markers that we use is, positivity rate, COVID-19 positivity rate that we use. That means if you do 100 tests, how many turns out to be positive? If you do 100 tests and 50 turns out to be positive, maybe you're not testing enough. If you do 100 tests and if you get 5, that is only 5 positive, maybe you're testing enough. And so currently in the last, I looked at national data now that is compiled by MKK. I think the last 14 days, our positivity rate is less than 5%. So currently we can say we are testing enough. But when there is a huge surge of cases in many countries, when there is a huge surge, the positivity rate immediately goes up. So when our current rates are low, we are able to achieve the less than 5% positivity rate, and so we are testing enough currently. Right?
Okay, okay. So we are testing enough. And what about and now we are testing people who are close contacts of positive cases, right?
So when emergency was ordinance was initiated, then the decision was to go for not go for mitigation but go for full control, because there's so much has been done to aid us in that process. And so recently, post emergency ordinance, Ministry of Health came up with a new circular that says that, you know, every close contact of a confirmed case will be tested and isolated irrespective of symptoms. In fact, they'll get tested twice. One at the time of you identifying somebody is positive, and one more 2 days before the isolation period is finished. So our current isolation period is 10 days. So 2 days before that, they'll get tested. So all close contacts will be tested at the time of diagnosis and 2 days before end of isolation period. And that's our current policy now.
Okay, yes. Thank you very much, Dr. Suresh.
And I just add what Dr. Suresh had mentioned is regarding that a new policy may come out as well, is regarding the use of the test, which maybe it will help the government in terms of cost, looking at cost benefits, that using the RTK antigens. So, you know, so I think that because these are the policies, you know, the contacts, the high risk area, for example, factories, old folks homes, and so on. These are targeted, right, in terms of screening wise. But at the same time, we also have people who are now willing to go and get tested as well, you know, and we wish that the government will come also with the shilling for the test, because right now the test actually it is not that expensive, but we are still seeing the private sectors are charging people more than what we thought, what we say a shilling that is both you know, in terms of for the company and for the consumers, it's a fair price, you know. So I think they are looking at it, because if you look at the cost in the Ministry of Health, the cost is not more than 100 ringgit for PCR, and for RTK it's not more than 50 ringgit. It's only about 30 ringgit and so on. So, but at the same time, we understand that for private, it is the time they consider, you know, the time they spend, the PPE. So we cannot look at the price in the Ministry of Health, because we only consider the reagent. We only consider the sticks and swabs. So when it comes to the company, private hospitals, and so this must be accountable. But we are going to put the shilling at one price for whole thing. So we hope that it is you know, it's marketable, it's competitive enough for them, but they will not make a loss. They still can profit from that, you know. So we hope that there will be ACTA fees for all these tests. So we hope that so that the consumers can see and compare as well, you know, whether the consumer will choose the place to go, and so this one we will actually not stop. And you know, so, and now I think we're also amending the definition, case definition, in terms of those with close contact, for example, who just had RTK antigen, rather than wait for because they wish to go and get tested in the private instead of, you know, waiting for PKD to come and get them tested. So these are actually people who will also be listed and defined as confirmed cases and may not need to repeat PCR. So these are the new things that is coming up. So, but I just wonder whether with this, then our number of cases will actually go a little bit higher than our numbers now, the new cases. So, but it will be temporary, isn't it? Probably a week or 2 weeks, and after it will start to be plateauing and come down, hopefully.
Yes, as you mentioned, there's so much of variability. RTK tests, PCR tests, and many centers are charging PCR for an RTK test, and then people feel the more expensive it is, the better it is. So I think some guidance on a uniformity, some sort of test that has high specificity and sensitivity that we can all adopt, I think that will go a long way to reducing the confusion for the people out there. Dr. Lachman, as a passionate educator, president of the College of Physicians, you have two roles. One is maintaining the service in the country, keeping it running, and also education, internal medicine, keeping physicians going. So there have been many obstacles, disruption in training of housemen, disruption in training of medical students, disruption in training of physicians, examinations have been scheduled, rescheduled, disrupted. What do you think has been the impact and how can we go about it?
I think we've been learning how to cope with this because it turned out to be longer than expected. In the beginning, we were postponing, asking medical students not to come to the wards, telling house officers you don't go into the COVID wards at all because of your inexperience. So we started with that because we thought this would be short, but it turned out to be quite long. So now we need to change the way we think about these situations and epidemics. Maybe, in fact, I think we should look at it as an opportunity to learn how do you deal in an epidemic. So we shouldn't be leaving out people, we should be including them, of course, with the enough training to be safe. And then let training go on, because you will not have this opportunity in future, or you may, but you do not know when. So as I mentioned earlier, infection, our exposure, our risk of getting infections from our patients and in a hospital setting is always going to be there from day one, even as a medical student. So it is opportune time for the medical students and us to make sure that you are taught properly, you train properly to how to be safe in terms of infection control, and let training occur. So there's another issue. What about the numbers? Medical students, there's nurses, there's postgraduate students, there's specialists, there's consultants, all in the same area. So that's a problem. And we need to also learn from this epidemic. If we do not want that, then we should take training to all hospitals in the country where there is care being done, where there's clinical care going on. So you spread it out and make sure there are specialists as well as there are trainees for that teaching to go on. And where there is training, the clinical care is better. And I don't think there's such a thing that, you won't get the ill cases or the different hybrid of cases in a variety of cases in the small hospitals. It cannot be. I mean, epidemiologically and statistically, ill patients will be everywhere. It's just that the procedures may be different. The more high-fied procedures may be done in only centers. But the presentation, learning from the patients, the signs, symptoms, initial investigations, the diagnosis, the provisional and coming to it can happen everywhere. So I think we need to relook at the way we train. We need to take training everywhere. And you use the IT systems that we have now to, if you can't get a specialist to a place where there is clinical care going on, where there's a trainer, then you do it online. Make sure that it's done on video and you observe it, the procedure is done properly, you discuss it on the spot. So training shouldn't stop, should go on. No one should feel left out. I don't think it's necessary to postpone, but we use and you do it in a safe manner.
I think the medical students and universities listening in will be very reassured with that answer, because as you mentioned, yes, training has to go on. And I think if you do not train now, this is the best time for them to actually get an experience and a flavor of COVID while they're medical students, isn't it? And probably the curriculum now needs to incorporate COVID-19. I think will become a very famous chapter, isn't it, in textbooks, and how we dealt with it, and what to look out for it. And I think PPE, I think, will become a standard chapter in the textbook. If you're going into a ward, what PPE do you wear? Do you use N95 masks, or do you need to use a face shield? I think it will become part of a curricula to come. Dr. Myran, you feel the same way?
Yes, I really thought I want to I want to talk about this, teachings. If you look at how we make the modules for students and so on, many times that we actually left behind the infection prevention and control chapter as a major one. I thought this should be universal to any undergraduates, basically those who are related to the hospital or health service, the nursing college, the medical schools, and so on. So because now you are expecting people to practice the infection prevention and control procedures anywhere from health facilities to the community and to other non-health agencies. It should not stop here. It will go beyond this COVID pandemic. And I really wish that everybody once graduated, they would know this one chapter that probably applicable to any disciplines they go. It's not only in medicine, it goes to surgery, it goes to the orthopedics, so this is a very big chapter that need to be part of the students' syllabus. I wish that it will be,
Just to add to what Myran said, historically, as well during the first SARS epidemic and even now, there's this thought that the COVID ward is the most dangerous place to get the COVID infection. But actually, what we know, even during SARS in 2003 and now, it is in the open ward. It's because you think you are safe and then you let your hair down. Oh, sorry, I can't let my hair down. So people think you're in a safe area and you don't take the universal precautions. So I think this is important to all our young to-be doctors, that you need to know well how to have protect yourself and protect others against this respiratory infection, as well as all other type of infections. And it should be universal. It should be universally practiced all the time. Thank you.
Very, very true. Yes, requires a change in mindset, as you had mentioned. A lot of confusion out there, isn't it, on the quarantine period, PCR checking. What's the latest consensus now? If you've been in contact, I mean, now patients, when they discharge, we're only doing one PCR, am I right, before they go back?
Yeah, I think I answered it a bit earlier. So our current, so it all depends on two issues, right? How much residual risk that you're accepting. Meaning, let's say I send everybody home at 7 days, no test, the residual risk is high. And so it's a question of what is the residual risk you are agreeing to accept. The gold standard is 14 days. 14 days is a gold standard, right? And so, but the issue was, as people have shown that the longer the isolation period, longer the quarantine period, especially if it's home quarantine, the compliance decreases. And so we'll have to come up with some sort of a middle ground. And so the current middle ground is the quarantine period is 10 days, but we will do one more test 2 days before the end of the quarantine period, so that we accommodate for the patients who have just got infected the day before the quarantine period started. So if they just got getting infected, you obviously your median incubation period is about 5 to 6 days. And so we are hoping that we'll pick them up if we do another test at day 8. And that's how we are doing it. So even with this approach, there is a 10% residual risk, and we think that residual risk is worth accepting.
Very true. So Dato' Suresh, a lot of patients, when they go home, they are always told that they can still be positive. And questions that we as doctors always get is, when they go home, the PCR can still be positive. How confident are we that they're not going to be infecting their loved ones at home when they go back, when the PCR is positive? Can we safely assume it's dead virus, or what exactly?
So I I agree with Suresh. You know, when we made a statement for mild to moderate cases, they will be discharged day 10, and even now we actually discharge them earlier, even day 7 onwards. But for these people whom been discharged earlier, less than 10 days, they need to continue the home isolations for another days that will complete that 10 days. So it's not going to be discharged and they are free in terms of having close contacts with partner, relatives, and so on. Yeah. So it's no and no. So we make sure that they discharge. But for those who had severe cases, we advise that it should be 21 to 28 days. You know, for those admitted to ICU, we de-isolate only after day 28. So actually it's very long time because there are actually studies to show that the most severe cases will have infectivity phase much longer. And I think the proof was that up to day 21. Lately, some people say it may be a little bit beyond than day 21, but we actually have put as day 28. I think for reinfection, I think it's very low, but it's quite difficult because you only need to prove based on culture. Second is genomic sequence, that you may actually have a different genomic sequence from the first one. Then only the chance that you may get reinfection is higher. Let's say if you now have variants in our population, it may occur more frequent. I think that was the same thing people are talking in UK. You know, the variants COVID-19 or SARS-CoV-2, the virus. So we hope that we will not face the problems. So I think putting as 10 days and also either 21 up to 28 days depends on the category of patients when they are discharged or had when they had been hospitalized. I think they actually safeguard. Beyond that, I think if they're going to check the PCR, as we said, it may go on even 3 months, 4 months, they can get positivity, but it does not reflect infectivity or live virus is there. It's a long time to actually clear the dead virus, you know, any proteins in there that will be picked up by the PCR. So it's not the livelihood of the virus that we pick up. It's just the presence of components of the virus that stays there.
True.
So
Thank
I
you,
think
Dr.
people has to understand those things, you know, infectivity and non-infectivity phase.
Yes. So now during this third wave of the pandemic, we seem to be noticing that the demographics are different. More of the younger people are being admitted and the disease tends to be more severe. Why do you think that is so? If that is so.
I feel that it may be related to our policy. The first MCO last year, we actually locked the factories, isn't it? No work, and most of the employees were actually not been screened, right? So it was just like lock, stop the work, and that's it. They mingle among them, but we never pick up except for a few places where you got symptomatic workers who stayed in one apartment or flat. Then we ambush the flat, and so. But we didn't really go to the factories, right? And there's big factories who actually during these MCOs are allowed to continue because they are considered as essential. For example, gloves, producing gloves. You stop producing gloves, then the impact is on us. So that's why you start seeing, cases being detected among the factory workers. And it's not about at work, but it's also the environmental situation where their residents, their quarters or their hostels or whatever was not up to the standard required by even the labor law and so on. It was really congested. So one person got it, the rest. But these people are very young, so they can only come to our country if it's legal workers. must be less than 50. So they are young, 40, and these laborers are not like us, having enough fatty food every day, and so they are very slim. I know that if you look at Indonesian, Bangladeshi, Nepalese, you look at them, they are very labor intensive workers, fit. Most of them are very fit. They are not like people in our community, so these are just like what the Singapore actually had faced. Number of cases jumped last year, but number of people who died hospitalized were actually much lower than us, even from the first phase last year. So this is happening to us now. It's only in the community that we are seeing the vulnerable group, a very sick patient from SARI, from brought in dead, and bad cases in the red zones, at ED, and so on. So the workers are usually very fit. So they are young, it's true, compared to our population.
And definitely. Now I think the go word is vaccines, isn't it?
Yes.
Everybody wants to go. Everyone has dreams of seeing the sakura blossoms in Japan, and everyone wants to see the Eiffel Tower, not in a postcard, not on Zoom, but in real life. So what is it with vaccines right now? Lots of vaccines being floated around, which is good. Older, younger. What's your input?
Less from the generals.
Yeah, I think vaccines is definitely welcome now. We have controlled many infectious diseases in the past through vaccines, and so this is another one is a welcome. Of course, in the country, everyone wants to know that it is 100% safe. Taking it, there'll be no side effects at all. But the reality is no such thing. In every intervention, every healthcare, be it a drug or a surgery, there'll always be some who will suffer adverse event. Basically, if you look at the data as it's coming out, there's not one single group that is totally contraindicated, but of course, those with previous known side effect with the components of the vaccine may have to be more careful if you already know you are allergic to it. If you have previous allergies to other non-vaccine related allergies, then you need to discuss with the doctor on your risk. When you discuss the risk, it'll be your risk of getting the infection, your risk of how severe you're going to have an infection if you get it, and your chance of having a bad reaction. So this has to be discussed, and in our country, it's voluntary. And this information is out there. So I think when it's voluntary, all of us as adults should get the information, have your questions answered, and make an informed decision. So I don't think we should divide ourselves into pro or anti-vaccine. It is there. You get the information, decide for yourself. And I think this is one way to control the whole situation. That's mine. Thanks.
Yeah, when we talk about vaccines, many people actually make a lot of statements, as Lesh had mentioned, is either for or against it. Yeah, but I think being people who are IT literate, and there's a lot of information in the internet about the products, I think you should actually look for it, not looking at flyers where is words by mouth, hearsay and so on, and you make that decision for taking the vaccine or not vaccine must be your decision. Okay, but at the same time, influencing others, I think is not right, especially when it comes to the negative. So you can decide you don't want to take it. Now the vaccine, actually, we are actually also learning about vaccines. You know, when first start, we have a few vaccines for Pfizer, the first one, Pfizer, BioNTech, and then second one, Moderna came along, and people start accusing that Malaysian is bringing in the China products or vaccine because, you know, you're going to vaccinate the high profile people in the first batch, you know, frontliners first batch, and the community will be left with the less the vaccine which is less good, you know. So I think that is just when we decide to take the vaccine, because I am in one of the member for selecting vaccine, we will base on their trial results on the vaccine efficacy in the trial. So we hope that we can select vaccine efficacy that have more than 70%, 80% onwards. That's the reason why Pfizer BioNTech was selected. The quality, despite having problems to look after the, you know, the transportation, logistic problems, storage, because of the requirements for the storage was very high, you know, with the BioNTech and Moderna. And with the same efficacy, then we look at the price as well. So there should be a shielding. So we some sort like giving the advice to MOSTI to actually make the procurement. So ours is selecting, and then we also have Jatan Kuasa committee to decide who will go into first phase, who will go into second phase, who will go and take up as the third phase, you know. So the selection of people to receive the vaccine, and then the logistic usually by pharmacists, how to handle the vaccine transport and so on. And now with the good news, we probably have to consider as well when the trial by the Pfizer, it shows that the vaccine efficacy after the first dose, it was only about 55%. But now at the ground level, at the field level, in UK, they have published that it went up to even 72%, you know, because this is important to make sure that we actually reach the herd immunity after receiving vaccine, at least 70–80%. That means people will develop antibodies for the vaccine after taking the second dose of vaccine, 70–80%. So if you, after the first dose, you already got about 72% vaccine efficacy, the question now is that enough with single dose? You know?
Exactly.
Single dose. But I think we still have to wait for the durability of the antibodies with single dose, or you may actually need a booster, you know, somewhere after a few months, because you will start to wean off and so on. So these are the questions we are still waiting. We were not going to embark on the policy yet, and we will wait and hear for that. With one single dose, Johnson & Johnson is coming, but I think they start going to market it and distribute only a few millions dosage of Johnson & Johnson. I think they already have the emergency approval for the vaccine authorization, emergency approval authorization from FDA. They will send to US. The US people will get it first, you know. Now, right now, US people is at least 30% vaccinated. Israel more than 50% vaccinated, and they have seen the reduction of new cases, hospitalization, and also death or ICU, because it's been shown that when you have vaccine, even if you acquire the infection, the viral load, you know, the SARS-CoV-2 virus load will be very, very low, and it will be less transmissible to contacts. So that's are the benefits. You may get it, but very mild. If you mild, then the risk to your partner or your friends actually will be less. So that's the motto that we said. If you take vaccine, it's not only for you, but for people around you who may not be able to take vaccine, you know. So let's say somebody who has severe allergy stays with you, your mother, your father. If you take vaccine, at least the chance for him to get the infection from you, you are actually considered as high risk worker in the health facilities who brings back to the family. So the chance for your parents to have the infection is much lower. You know, when you compared to if you were not vaccinating yourself, getting the vaccine yourself. So this is the message, you know, save you, save others. That's the reason as well.
What about the thought that some people are saying that Sinovac is a easier vaccine, preferable for the elderly? The Pfizer has more side effects, more efficacious in terms of inducing an immune response. So there's a lot of talk saying that the older people should go for the Sinovac vaccine and that the youngers take the Pfizer vaccine.
I actually had reviewed the Sinovac papers because I'm in the selection. I think maybe Suresh also had received that. You know, the problem with Sinovac is not that it's not good vaccine. It has reached and passed the marks of more than 50% efficacy. There is only the requirement for WHO, 50%. But their papers, when they do it in this country, the vaccine efficacy is only about 60%. I don't want to mention the 3 countries they tested. In this country, they said that they produce 80%. And then another country is only about 70%. So you see, even with one vaccine, there's a variation in terms of the efficacy they produce. You know, it is not like the difference of 5%. The difference is about 20-30% difference from one country to another country based on the trial results. So for us, because these are the phase 3 trials, all of them were phase 3 trials, you know. So I'm sure that from that study, they actually sent to us for it to be registered. And I wish that there will be another paper that will come out to say what is their, at least on average. Now their average is about 70%. So we hope that in terms of the quantum of vaccine now, I think we actually got Pfizer, the highest, probably about 50% of the lot. And then after that will be the Oxford one, you know, that one, the one which has a vaccine efficacy more than 70%. So we are trying our best to get the best vaccine to our people, you know. And actually Johnson & Johnson is probably another one in the 3rd phase, which probably will give a better compliance because you need just one jab and off you go. But Johnson & Johnson also are starting to do a trial whether they will also go for a second dose to have a better yield compared to the current yield, which is vaccine efficacy is about 80%. You know, whether they can boost as equal to as Pfizer, 95%. So people are actually continue to do trial even after marketing it. So we hope that we get more results for that.
So that's a question that the panel also asked, students have asked, if someone gets a live attenuated virus, can they be infective to others?
At present, we have 2 in the market so far, isn't it? Not the live attenuated. But once you have attenuated, then the risk to the immunocompromised patients, you know, you may pose the risk to immunocompromised. So now what we have actually is the mRNA, which has probably no influence on the immune status of the people who receive that or been having the acute infection as a result of that. And the second one is, for example, like Johnson & Johnson is using the vector, another virus, adenovirus, bringing in the protein to activate the antibody against the COVID-19, against the SARS-2 virus. So the live attenuated one, we're still not sure what's the results, right? But I know we need to guard in terms of people who actually receive it, especially the immunocompromised patient.
True. So back to education again, seems to be a very recurring topic from our discussion. So someone has proposed that medical students should not waste time, and the schools should start integrating the lessons that we're learning from the pandemic right now itself, while trying to make up for lost clinical time and practice. I think the ones who are most affected are the final year medical students. How do you all feel about that? What can the final year medical students do right now? What can universities do right now? Because we are from the MOH, and what can the MOH offer to these universities to lessen the impact of not having clinical exposure over the past year? Dr. Lech.
I think we just have to carry on with the training and the examinations, but in a more safe manner. And I think both the educationists and the clinicians have come to some learning over the past 1 year on how to do this. The exams now, I notice, even though there are several components, for example, in end of final year examination is clinical as well as Viva, there's OSCE. So things are changing. Some of the Viva is now held online. So you are reducing the contact time, the period where people come together too often. So you are making it safer. The physical examination part is also being carried out. I was involved in one exam, and the precautions are taken, the spacing, the breakout time where everyone has their meal, you have it separately, you don't have it together. Patients wear their mask as well. So it can be done. So that's about the exams. With regards to teaching, I think some of the parts where the discussion can be done online. And then when you want to show clinical signs, and you go in with small numbers, show the signs. And then when you want to discuss, you go out of the ward and everyone will be in one corner and you join in your video conference and discuss it. So these are means, and we have the medias now to do so. So basically, we have learned the past 1 year and we need to put it to use, and training should not be delayed. I agree with the students who said that.
Very true. So I guess the hospitals also have to be proactive in recognizing that these students still need training. The usual response probably will be like, we've got enough on our plates. The last thing we're thinking about now is what to do with the medical students in our wards. We're probably worried about the PPE and what's going to happen. But I guess you are right. We need to come together. Dr. Mahan, how do you feel about that? Kelantan, USM.
I said that there may be a little bit of a very in terms of options to deliver the training materials, isn't it? As what Dr. Lech had mentioned, there are a few. But I remember during my college time, the university in Cardiff, we used to have at the end, you can go and work in the ward, but like we have session for neurology, we do it in the auditorium. And then, there'll be 1 or 2 people who will examine the patient. It will be like broadcast. So people, the other students in the auditorium can see the actual examination techniques. It will be broadcast, and there will be neurologists there, and after they explain about. So we were actually doing that. That was 30 years back. And when I was posted to the district hospital, we have this kind of teaching already, the live online thing, that there will be questions and answer session, presentation, case history, like we do the grand walk around now, not going to the patient, but x-rays, everything being, discussed, investigation results. So it's like, so we should not waste saying that once you cannot go into the ward, no teaching can be done, a direct discussion on clinical case. So you may allow 1 or 2 students to go and cloud the patient and make it as a presentation on slides and discuss it live. So I think it must be very innovative. So when I think about that, we had gone through about 30 years back, But so now with all these IT gadgets, every day, you know, last time we need to be gathering in one seminar room to look at the LCD. Now you have everything. Everybody can just watch, be this one, and you know, be interactive enough. I think that should not be a problem. It's not like having complete no. You may actually have only 1 or 2 students going to clock the patient and they come out doing the presentation, you know, towards the evening and so on. So it can be done. So this is part of the other. We cannot have a crowd, you know, examining patient like 5 of them, 8 of them with the, you know, bedside teaching. So that means if you have 10 patients, good patients, maybe for this time 3 patients with 2 each, you get 6 students, you know, manage to clock the patient for that day. And they share their experience. The next day will be another group or something like that. So innovative way of teaching, make use of their phones, their IT and so on. So it's good. I think it can be done. I know this, we're not sure whether it will be in 2022, you know, this pandemicity will only, because the aim is that once you get about 70 to 80% vaccination, you know, then we will probably back to the usual activity with our new norms. And when it comes to new norm, you cannot have a big crowd of students still surrounding the patient. So it must be in the small groups.
But I guess, as you said, we have, because now it's COVID-19, by the next time we may have COVID-22, another coronavirus may just pop out. And we're going to go through the same thing again. And we can't wait for vaccination. If there is a time to change, it is now. Nobody used Zoom 1 year ago, isn't it? If you ask somebody to come on Zoom for meetings, they look at you in a funny way and think that you're lazy, that you don't want to come for the meeting. But now everything has become Zoom. And we embraced that change very well. And I think you're right, that medical students and universities now need to look forward at, look, this is going to be around. We are definitely going to get another coronavirus in another 2 or 3 years again. And at that, you know, we don't want to be scratching our heads then. Another question that keeps on coming up is H1N1. No one seems to be hearing anything about it. What do the ID guys have to say about it? Is it because everyone's focusing on COVID and H1N1 is not being picked up, or what's the story with H1N1?
It is not the story about H1N1. It is there, isn't it? Suresh? Dr. Suresh will say the same thing. It's around us. The only good thing about, we don't see that now, but because like last year, remember in November, December, there was a bit of hoo-ha among the pediatricians and also adults, primary care, saying that they were seeing more H1N1 in 2019. And there was a good, 2019, there was a lot of articles, papers, you know, whistleblowers, blower during that time. And that one thing I remember that it was a very good red alert for us, because that was the time I was pushing for Ministry of Health to have SARI syndromic, as Lesh had mentioned before, you know, more tests been done to see whether we are really seeing H1N1, because the private practitioners are actually testing the point of care testing using the kits for influenza A and H1N1. So they said that it was on the rise. Even a few months before that, I think there were articles from US saying that they were actually seeing a lot more H1N1 from US. So, and at that time also, because people were panicking, you know, PPE was actually running out because we were not prepared. You know, outpatient department were asking for more PPE. Suddenly, hospital were asking for PPE and so on. So I remember that time, Dr. Suresh, we were actually having some sort of like policy making guidelines on we put that under SARI, you know, because it's not confirmed, and actually pushing the lab as well to equip themselves with all the PCR, you know, to confirm the H1N1. Right now, when you actually have the social distancing, mask, and hand hygiene being promoted in the community, it's probably I would say, partly helps the H1N1. It is a circulating H1N1 is there. The only thing is the search, you know. And we learned that there also has that variance, you know, change in terms of seasons, and also, you know, they may actually be more pathogenic. Luckily, it's not more pathogenic; it's the usual seasonal flu. So with all this distancing, with all this masks, actually it helps to curb down the H1N1. And we actually doing the surveillance for ELI now, with even PCR for COVID, but the sentinel surveillance will go on to see whether there's a surge in H1N1. I have not seen the report as regard to the sentinel surveillance, whether it has come down. Do you see, Dr. Suresh? For last year, whether it has come down or not?
I'm not seeing, but I think that the WHO report does say that in the region, the influenza rates have come down. And because of all the social distancing measures.
Suresh, can't hear you well.
No, as mentioned by Myran, the WHO report does say the whole region, the influenza rates have come down. And I think partly because of the social distancing measures that were created.
Yeah.
Yes, that would be true. That would be true. The David Chan, one of our one of the questions that was asked was, we definitely need a country-level ID task deployment plan and strategy, like what Taiwan did. I believe that's already there now, isn't it? What Dr. Suresh and Dr. Myran, this rapid deployment plan. Similar to what was done in Taiwan. So I believe that we will be better prepared for the pandemic to come. Lots of questions still popping up, but I believe we are running out of time. At this point, I probably think it is only wise that we thank our panelists for being with us here today. Dr. Lechuman is nearing the end of his term as head of service for the country. I believe he has spent many sleepless nights. Two people who are rumored who don't sleep were DG, Tan Sri DG, and Dr. Lechuman. WhatsApps till late in the night. I'm sure Dr. Mahiran and Dr. Suresh also get irritated by Dr. Lechuman's WhatsApps late in the night and first thing in the morning. Right? He doesn't sleep and he doesn't let others sleep. But I believe that it is because we have such dedicated people like Dr. Lech. I think Dr. Suresh, I remember him from those days in HKL with Dr. Chris in Ward 23 and Ward 24, and now at Sungai Buloh. And Dr. Mahiran in the north of the country. I believe it is your sacrifices that you have made for the country that have kept it going forward. We thank you, all of us, for keeping this effort going. And I'm sure there are many sacrifices that are made by many others, but I do firmly believe that leadership starts from the top. And I believe that your leadership in these testing times have made a big difference to COVID-19 handling in the country. And Dr. Lech, and also as College of Physicians, I know he's very passionate about education. And even after he finishes his term, I'm sure he's still going to go on teaching people and irritating people till late at night, asking them questions and until the next morning. So education always continues. And I think today is an education forum. We all are here to learn from it. Malaysia thanks you all. I thank you all. For me, it's a great honor to share this screen with great people like you who have mentored us. Thank you for your time. Over to you, Prof. Chris.
Thank you, Dr. Paras. I'd like to thank all of our speakers today. Firstly, for giving us their precious time over a weekend at really such a very busy time. Secondly, really, for the series of excellent presentations that everyone has given and for the thought-provoking discussion that's been initiated during this panel session. And I'd also like to particularly thank Dr. Suresh, because I've noticed him typing a lot of answers into the box for the questions that have come from various people. So thank you very much for that. I'd also like to thank everyone at NewMed for organising today's event. It really has been a real team effort. And I think hopefully that everyone will agree today that they've done a fantastic job in ensuring that everything has been such a great success. I'd also like to thank a special thank you to our dear friend and colleague, Datuk Seri Dr. Paras Doshi. All his advice and all help in setting up and organising and also for moderating the panel discussion. So thank you very much for that. Finally, I'd like to thank all of the delegates and everyone who's come today. I hope that you found this morning both interesting, stimulating, and I hope you have a very successful afternoon in the training sessions that I know many of you will be going to. I look forward to seeing you all at the future masterclass events that NewMed will be organising over the coming months. And so please look out for the adverts on Facebook and our other social media feeds to register for these events. So thank you very much, and I'll now pass back over to Pramila.
Thank you very much. Ladies and gentlemen, we have come to the end of our first session. If you have signed up for the Training Pathways breakout session, please refer to your email for the Zoom link of each session. If you are facing any technical issues on your Training Pathways Zoom link, please contact us at WhatsApp number 016-667-8245.